according to the demand by Dr. Ayman Fakhri, I divided my presentation into some sections. So in some part of the presentation, I will stop and we will discuss on it, and then we will continue to the next topic. So I will go on now. I will just try to start my presentation with the indications of venous stenting in post-thrombotic syndrome patients. The most important thing is to decide which patient should we stent or not. And the most important thing is, should we stent every post-thrombotic syndrome patients with iliocaval or iliofemoral involvement? And definitely the answer is no, because we should stent the patients with real symptoms and real problems like venous claudication, like venous ulcer, and like decrease in their quality of life. That's very important, because there is no need to make such type of procedure to an asymptomatic patient, because the patients should feel any improvement or benefit when you give them a therapy. And this is very important. So you are giving a very, let's say, important therapy, and if they don't feel any difference after then, so you do it for nothing. Of course, we start with the preoperative evaluation. What we do, and we know that we should get very detailed, let's say, history, and also the physical examination is very important. Especially you should look every possible signs, starting from the legs and going to the abdominal wall, to see if the patient has such type of collaterals. And according to the literature, we know that if the patient has such type of an abdominal visible collaterals, more than 90% we are sure that there is a central vein occlusion. So it's important to see such type of collaterals. And of course, we have our diagnostic tools. And from my point of view, the most important part is starting with duplex ultrasound, so which is easily available, and if it is done in good hands, it gives us a lot of, let's say, good information. So we should start the level of liver and continue to include crural lower extremity veins. And we should look for compression syndromes, intraliminal scar tissues, if there is the lumen reductions or recanalization percentages, existence of collateral vein and the direction of flow in those veins, competence of venous valves and their places, so venous insufficiency and its grade. So we should look for every detail. And again, of course, we have our the other diagnostic tools like CT and MR venographies. So both is valuable in post-thrombotic syndrome patients, but MRV is superior to show intraluminal scar tissues and the collateral veins. But sometimes it is really difficult to have some good images with MRV. So it is changing from center to center. So I think the most important thing is which one is available for you and which one is you are having good images. So you should talk with your radiology department, because having a good MRV sometimes becoming difficult. So you should have a good protocol. And of course, we have the IVUS. And the IVUS is mainly used during the procedures, but we have a lot of information during the procedures. We have let's say, the compression points. Again, we see the intraluminal scar tissues. We see the orifices of collateral veins. And of course, it's beneficial for determining the stent landing zone. So we know that we should make the stenting to the healthy side. So it's very important to get real information from IVUS. And it's also very beneficial if we use it during the procedure, because it also decreases the exposure of, let's say, radiation during the procedure. So it's important to use it. So as you see here, we can get real good information about the vein wall and about the diameter. So we can also make some measurements, and it is very helpful to us. And when we come to the venous stenting, we have two types of stentings. Which one is the most used? Maybe the percutaneous interventions, and the other one is the hybrid procedure. So when we do it hybrid, so we combine it with surgery. We are, let's say, adding endophlebectomy and arteriovenous fistula. But the most difficult question is, which patient should we do it percutaneously, or which patient should we do hybrid? So this is the very important question. As we know that also we presented this classification during the Egyptian Vascular Summit. Dr. Human Jelay has a new classification regarding the involvement of the inflow vessels. So this is a very important and simple tool that we should decide what to do, at least for the, let's say, beginner centers. Sometimes it's really difficult to have an insight that we should do it percutaneously or hybrid. So when we look at this very simple and beneficial classification, the first one, the class 1, is the non-thrombotic, let's say, compression syndrome, as we know it, May-Turner. So it is, hopefully we know that everybody is, let's say, has a good consensus on it, that we will treat those patients endovascularly. And for the class 2 and class 3 patients, again, we do it for the endovascular procedures. But if one of the inflow vessels is involved, like the femoral vein or the deep femoral vein, then either we can do it hybrid or endovascularly with stent extension into these inflow vessels. So in order to be able to do a class 4A and class 4 patients, we should have some dedicated venous stents, because you know that the wall stents is not that good below the inguinal ligament. So we should have some dedicated stents to go through the inflow vessels. And the class 5, including the both inflow vessels, it is difficult to make those procedures endovascular way. Either we should accept it as a contraindication, or we should do at least, as we know that from the Dr. Garcia's results, XSPTS study, we can do it with, let's say, in combination with such type of therapies. And the inflow assessment, I think the most difficult part related with the, let's say, venous stenting, because we are deciding our procedure according to the inflow. So, and unfortunately, so far, almost all techniques or all the results are mostly subjective, because we are not able to give such an objective data that you should do, you can do it with, let's say, percutaneously or hybrid way. All of them is, let's say, subjective procedures, and I think mostly it is the experience-based information. So we are looking at the inflow venous segments, and then, of course, one of the important tools is measuring the volume flow with the duplex ultrasound. Unfortunately, at the moment, we are not able to give such a level of, say, that we can say that, okay, 100 milliliters flow is okay to keep the stent open. We don't know it for yet, but with the MASTIC group, we are now collecting data, and I think in a very short time, maybe we will be able to give such a number, and it will be, I think, one of the most useful data to know it. Of course, we should also look for the collateral veins, because some of the collateral veins, if we don't care for it, it can steal your flow, and then it can cause your stent occlusion. So that's important, especially the crossover type of collaterals, like the palmar pubic vein, or the superficial branch of external pudendal vein, or the medial circumflex vein, the obturator vein. So these veins can steal your flow, and then it can cause some stent occlusion. And then, of course, we have the intraoperative measurements, like the picture you see on the, let's say, slide. And with giving some contrast, you can have some insight, and for the washout time, you can have some insight about the flow. But these are all subjective. And we try to make such a simple also scoring system related with the scarring amount of the, let's say, inflow vessels, and we try to give some simple scoring, but it's also not 100% correct, because when you scored all these inflow vessels, and if your score is, let's say, above 8, so it can go through an percutaneous procedure, but if your score level is below the 8, it can be an hybrid procedure. And also we have an also article from Dr. Jerry O'Sullivan, and he tried to make a, let's say, analysis of inflow by combining the CT venography and the let's say, simple contrast venography. But as a result, we see that he also cannot give us, let's say, objective results related with whatever tool you use. So it's mostly, again, the experience based. And when we look at the principles in venous stenting, you know, it is different from the arterial side. So we are going through one of the multiple channels and we are just dilating at stenting. So for this part, it's okay. We can discuss on it, especially for the inflow assessment or the preoperative tools. And I can get some questions.
Okay, great. It was a very nice talk. Now I ask the attendees, please, if you want to ask a question, either to raise the hand, go for the raising hand, or you can write a question.
I would like also to ask if I have the possibility, Professor Swat. Thank you. It was a great presentation. And if I would like to ask you and all the famous panelists, how do you assess the inflow to your iliac vein if it is occluded? We all have this problem. We know that CTV or MRV is not accurate. We don't know what is the actual limit of flow. So I would like to ask the panelists, how can we assess the inflow, which is mandatory before you put an iliac stent, that it is sufficient to maintain the stent open? I would like to ask Professor Munir Nazal, Professor Loyal, Professor Swat, Mus'ad Suleiman, and Mark Whitley, all the panelists. What's your reply, Professor Swat? How do you assess, what is the best investigation to assess a good venous inflow to your iliac vein occlusion?
Yeah, actually, I always combine it two techniques. With first, of course, we have the CT venographies or MR venography. So we look at the inflow vessels involvement. And it's not, of course, enough, because you should always look at with the duplex. I am checking with the duplex, let's say, for example, for me, the most important, one of the most important inflow vessels is the deep femoral vein. So I always look at its orifice and the coming flow amount. So although we cannot give maybe at the moment a good number of flow, but mainly according to my experience, flow at the level of common femoral vein, about 200 milliliters per minute, it's mainly is a good inflow. But if it is below it, so it can be not good, let's say, amount of inflow.
What about Professor Munir? What is your opinion, Professor Munir?
So, in my opinion, when there is occlusion, so this is why we do the procedure, because there is either thrombosis or occlusion chronic. To evaluate the flow through the collaterals, it's almost impossible because there is occlusion in the first place.
Yes.
It is not important what is the flow before. What is more important, the flow after, what will happen when you improve the occlusion. So we used to do ultrasound, and then by ultrasound, you see if it is what we call swirling around itself, and then there's hardly any flow, but we found out actually swirling because there is occlusion. So pre-op evaluation, I'm not sure how important it is, although we are trying our best to find out pre-op evaluation. But after the procedure, once you stent and balloon and everything, then when you shoot a dye, if it moves very fast and the collaterals disappear, you know there is actually better flow. But then it's too late, you already stented, so it will not help you to choose. So my opinion, the pre-op evaluation is mute because there is occlusion. It's not arterial disease, it's a venous disease.
What about Professor Kapnick? What is your opinion, Professor Kapnick?
So I agree with the previous panelists. I would make sure that before I start, that I know what the profunda vessel, common femoral vessel look like. Because if they have disease, then that's going to be something different in terms of looking at outflow after I've alleviated the stent. So I think that's important. If you have a good profunda and you've alleviated the upstream pressure, which is getting rid of the stenosis, and the collaterals disappear, and you get that quick dye run out, I think you're good. But as we've heard, we don't have a great number, objective number yet, and I'm looking forward to that.
Okay, what is your opinion, Professor Mark Whitty?
We don't actually deal with these. We're very office-based, and so I refer these on to Stephen Black or to David Beckett to do these. The only thing I say is that we do in the office first. We obviously, we're also great believers in doing the air plethysmography, Chris Latimer's technique, not the double cuff, but the single cuff. And we trust that, but apart from that, I bow to other people's expertise.
Okay. Any other opinion from the panelists you would like to add?
I want to ask another question.
Yes, you can go ahead. Your voice is open.
Yeah, almost we all agree about these techniques for assessing the patency for the iliac vein. What about the indication of the hybrid room or the hybrid method? I think it will be plus 4 and 5. That's when we go for hybrid. Do you agree for that, Swat?
Actually, I couldn't hear it exactly, but I think you are talking about the hybrid procedure, right?
When you go for hybrid technique, I think for class 4 and 5, you agree for
that? Especially for the class 4A and 4B, if you have a venous stents, you can still go through a percutaneous procedure to directly go into one of the inflow vessels, and the main inflow vessel, you can get the blood through directly from those vessels. So for those type of classifications, you should have some dedicated stents that it will not fracture at the wall of ligament. But if not, you cannot. If you cannot get the blood from directly from inflow vessels, it's not possible, or it's not favorable to do it in percutaneous vein.
Okay, we have a question, Professor Ayman and Professor Swat, from the chat room. What is the Gracia method in management of PTS? What is the Gracia method for type 5?
The Garcia method is, you know that Dr. Garcia is now making the access PTS right. He is at the first day of procedure, he is making a ballooning and then putting an echoes catheter. We know that it's ultrasonographic activated catheter. He puts there, it's over 24 hours. And then for the next day, he is making again balloon dilatation to make an inflow augmentation. So it's giving an opportunity for class 5 patients to be stented, but when you look at also his results, it's also not that good. So it's around 60 or 70% of patency rates after such a procedure, but at least you are giving an opportunity for such type of patients.
Okay, I think we can continue the second part of your lecture.
Can I have one more question, please, Dr. Omar?
Yes, please.
Dr. Sard. Thank you, Dr. Sard. If there is any method that pre-operative or pre-procedure, can you assess if the lesion is passable or impassable?
You mean the recognition of these post-thrombotic veins?
We don't know if it is thrombotic, it is easy matter, but it's a chronic occlusion, as Dr. Munir said, it is very difficult matter. Can we assess if chronic occlusion means many times it is impassable lesion? Can we assess this before starting the procedure?
Actually, if when you look at from the CT venographies and MR venographies, you have the insight about if it's a chronic total occlusion or if it is not, but also you can look at it with the duplex also to see if there is any flow or not in those chronic, let's say, disease vessels. But even it is, let's say, very chronic total occlusions. If we go find a let's say good channel, many times it's not that difficult, because when you look at the literature, the, let's say, unsuccessful procedure rate is between 10 and 40%, 10 and 15%. So many of those patients still can be done, especially if you are in the right track and go through the iliac segment.
Yeah. Okay, thank you.
You can continue, Professor Swat.
Okay. Now, in this part, I will talk about the technique of stenting. So, when we look at the percutaneous way of stenting, of course, first we should start with the access to the vein. So, especially, we are many times we are puncturing the femoral vein from mid-femoral part. So, and then we put our let's say introducer sheets. It is really sometimes can be challenging also, because as we know that at the level of Hunter canal, it's mainly they are, let's say, opposing each other, and then the artery and the vein are on top of each other, and we know that the vein is fibrotic, and it's a very small in size, so sometimes it is also can be demanding. So you should try to find a good way for puncture. And if you are lucky, at some patients, we know that the vein and the artery is sometimes not just opposing each other, and then it is a bit away from the artery. So for such type of patients, it's very easy to puncture the vein. And the most important thing is tip of our sheet should be beneath the disease segment. So we know that we have to, let's say, make a stenting between healthy sites. So it is really important. And the second issue is, let's say, recanalizing. So the passing through the disease segment with some hydrophilic guide wires, the size can be changing, but I use many times 0.035 hydrophilic guide wires. So it is really helpful to pass through. And sometimes I use some stiff hydrophilic guide wires, and it's also helpful for many of the cases we can do it. And it is the most important part of the procedure, because if you pass through those disease segment, you can do any type of procedure. But if you cannot, you cannot do anything with the procedure. So sometimes really it is taking a lot of hours. From my practice, I know that even sometimes 5 or 6 hours just trying to pass through those disease segment. I talk like that it is like you are walking in a maze. So if you are in the right track, okay, it's easy. You just go through it, and then you reach the healthy caval site, and it's easy. And then sometimes it's not, because you are going through one channel and it's occluded. You cannot go further. You should find another channel which will take you through the healthy segment. And if you sometimes if you cannot go through the let's say from the femoral part, you have to come down from the jugular side. So you should also prepare the patient's jugular side just in case of puncture during the procedure. And for such type of cases, sometimes you can, let's say, need a snare to get the wire from the jugular side. So in your armamentarium in the OR, you should have such type of tools to help you. And when you pass through all disease segment, again, at that time, the next step is starting. So we are making the predilatation. So we know that these are all very fibrotic and disease segments. The predilatation is really important, because if you don't predilate, you cannot, let's say, open your stents there, because although we know these are very, let's say, strong stents, so they have good radial forces, but believe me, the is stronger than your stent. So you should first predilate and then try to open your stents. So we use larger balloons, especially for the caval part. We are using, let's say, balloons over 20 millimeters, and for the common iliac vein, external iliac vein, the common femoral vein, we are using 16, 14, and 12 millimeters. So this predilatation step is very important. And then when we go to the stenting, we should select very good sizes, because At the cava part, 20 and 24 millimeter is okay. And for the cava, 14 to 18. So we should measure it during even the procedure with the IVOS, or before the procedure with your CT venography or MR venography, because if you use small size stents, so they are causing some, again, resistance inside the vein, so it can cause maybe early stent thrombosis because of the resistance. But if you are using, let's say, two large stents, then those type of large stent is causing post-stent pain, and post-stent pain is an also important issue. If you use especially larger sizes, those patients are really feeling stent pain afterwards, and especially for the rigid stents like wall stent, the patients are experiencing more stents than the dedicated ones, because those are flexible. Sometimes those flexible stents has such type of benefits. And afterwards, we need to make the post-dilatation. It is really important, because in any kind of stent, if you don't post-dilate it, they don't, let's say, fully dilate according to their correct sizes. These are really hard and fibrotic veins, so you should always make the post-dilatation. So it is very important. And for the hybrid procedure, now we know that we are adding the surgical part. So we are preparing the, let's say, artery and the vein. So all bigger side brains are taped. We are trying to, let's say, to be cautious, because all those vessels can bring some amount of blood to your stent. So you shouldn't ligate those veins. So you shouldn't harm those veins. These are very important. So after you are sure that you, let's say, taped all the vessels, and then you are making your venotomy, and after you open your veins, you will do the endophlebectomy, and you should close the vein with the patchplasty, because it's important, you know, that those are all fibrotic vessels. So if you don't do it with a patch, you are also narrowing the vein if you do it with primary repair. And you can do it, but I don't advise you. And then you are making an AV fistula formation. The next steps are the same with the previous one. So in this picture, you see that we taped all the collaterals, and then we opened the vein. And as you can see here, is that this is a not anymore, and if this is a thrombus, this is a collagen. So you should carefully dissect it with, let's say, sometimes you need some sub dissections, and then afterwards you fully clean inside the vein, and then you finish it with bovine pericardium and then AV fistula formation. So when we came to the AV fistula formation, so what type of fistula we use? We know that also this loop-shaped fistula is again offered by Dr. Humangelai. They made several studies, and if you put, let's say, not loop-shaped stent, and if you put the stent such like caudal way, then the flow of the fistula is making a resistance against the inflow. So with such type of, let's say, fistula formation, your inflow can be affected, and it can cause fistula loss. So the most favored one is this type of loop shape, and we are using, let's say, 6 millimeter PTFE ringed graft to make such type of fistula formation. So by this way, after some time, when you need to close the AV fistula, you come through the contralateral arterial side, and you can easily put some vascular plaques, and you can cancel this AV fistula. So here, as you see that there is a patchplasty, and you put your 6 millimeter graft. As I told you, when you decided that, okay, you don't need this AV fistula anymore, and then you come through this contralateral side, checking the stent again, and then you put this plaque occluder, and then the fistula is totally occluded. And it's a very easy procedure after you decide to close the fistula. But the most important and difficult part, again, the most maybe we should discuss on this, when we will close this AV fistula. It's again a very difficult question. Maybe we can discuss on it. And when we talk about this, especially for the KVAL involvement patient, so the confluence configuration is again an issue. You can make such type of double barrel configuration, apposition, fenestration, confluence, and skip the lesion configuration. So many of them is done with a lot of our colleagues, especially with the double barrel technique. We know that from the study by Dr. Roman Jalai, for such type of double barrel technique, for the metallic parts, they are touching to each other. The endothelialization is not happening, and then for such type of configuration, due to the non-endothelialization part of the stent, it is still more thrombogenic than the other parts. But for the other three techniques, there are, if you make such type of apposition, fenestration, or confluence technique, since at least you are coming from both sides, maybe just an example with a 16 millimeter stent, so it is becoming 32. If you put those 32 millimeter stents into a 24 millimeter KVAL stent, you increase the, again, resistance, and it may cause a problem. That's why for the last, let's say, year, maybe we are using this skip the lesion technique. We are not putting the iliac stents in the KVAL part. We are just putting them below, just below the KVAL stent. So these are not, these are having really good results. We are happy with this skip the lesion configuration. And especially when I started my practice making for the, let's say, KVAL patients, I was having some hesitation, especially if you use some closed cell design stents. If I put it, am I damaging the renal vein? So also some of our colleagues have the same hesitation with me, so they make a good study for us. So they tried such type of three configuration during the KVAL stenting. And there is a, let's say, this is a Z stent, these are wall stents, they're sparing the renal vein or covering it. So when you look at the results of this stents, any configuration you do, the renal veins is not affecting from such type of configuration, so you can do any type of configuration. So this is the end of this part. Again, we can have a discuss.
Excellent. Thank you very much. That was great. I did look at the question and the answer bottom, and the Professor Kabnik wanted to answer the question about what about the Gracia method. So Professor Kabnik, you can have your feedback.
So I agree with what was said about the Garcia method. A lot of us don't practice that method. So the statistics that he had were very good, but I have not practiced that method myself.
Okay, fine. Let me take this great opportunity, ask the panelists what is the stent configuration they like to do. Professor Munir Nazal, Professor Mark Whitley, Sergio, what everyone tell me his opinion from his experience. What is the stent configuration out of the 5 configurations that's been presented by Professor Uswad? Professor Munir.
So first, one of the tips really to cross that if you go from the internal jugular vein or the femoral vein, to keep a long sheath with a dilator inside it and use it to help you to cross. It will improve the pushability and actually give you more chance to cross if you fail. So keep the dilator inside the sheath very close to the occlusion and try to manipulate it. The second thing about the stent, really, we choose to stop at the IVC. We don't like really to cross unless by mistake or the stent moves. But most of the time we choose to stop near the IVC or the IVC. I learned that honestly from Dr. Peter Neglin. If the occlusion extend into the IVC, in some cases, we overlap or we do the skip area. Depending on that area, if it is scarred, difficult, I have to cover it. Otherwise, there's no point.
Okay. And what's your opinion, Professor Sergio? I know your mic is on. He's not with us. Professor Alexander, what is your best stent configuration for iliac occlusion? The mic will open now. Mr. Khalid, if you can open the mic of Professor Alexander.
Yeah, I'm very proud to be here in this forum. Welcome to everybody. Unfortunately, I did a lot of stents in the pancreatic system and in the biliac system, but I'm not doing any more stents in the deep venous system.
Okay.
I'd like to weigh in if I may.
Yes, please.
We talk about configurations, we talk about skipping. We really don't know. What objective measurements do we have? Is a patient better? What's our occlusion rates? So depending upon who you train with, depends upon what you're going to do. And I would submit to you that Dr. Neglin does go into the into the IVC, because that's what he did originally with the wall stent. Now that the wall stent is approved in the United States for venous position, the wall stent for me, for May-Thurner type lesions, is perfectly adequate. When you get into thrombotic lesions, I'm not sure about that. And when you go up to the cava, I think that we have to be very careful if we're dealing with May-Thurners not to jail the contralateral side. So I think that there are stents there that, especially dedicated venous stents, that may flare, that may be better use. So I think you have to be careful, but we don't know the right answer. So we're all speculating here.
Okay, we got a question from the Professor Mahmoud Salah. He said, when do we do augmentation arteriovenous fistula? He would like to know Professor Suat's opinion and the panel's opinion about the indication. When do you do augmentation arteriovenous fistula? From Professor Mahmoud Salah.
At the first part of the presentation, we focus on that. If the inflow is not sufficient, we are trying to make the inflow augmentation by making the endophlebectomy and putting the AV fistula. So by this way, when you make the endophlebectomy, so you try to clean all the, let's say, this collagen type of tissue inside the common femoral vein, and then you are cleaning also the orifices of the, let's say, deep femoral vein and other important big collateral that brings some blood to your stent. So, and by this way, you are cleaning up the vein, and then you put the, let's say, AV fistula, because we know that after such type of procedure, the inside of the vein is becoming very thrombogenic. So you put the AV fistula, and then you try to, let's say, increase the flow, and then by this way, you are trying to keep your stents open. So the idea of also putting the AV fistula is just increasing the flow passing through your stents, and it will help us to cover the struts of the stents with the endothel. And when the struts are covered with endothel, the stents are becoming less thrombogenic. So at least you should keep your fistula 6 weeks or more. And according to my practice, you know, at least maybe half of the patients after closing the AV fistula, you are losing the stents. So sometimes maybe I think we should discuss that. Maybe we should just not do any procedures for such type of patients. Maybe if we are using half of your stents. So now in my practice, now I am trying to keep those fistula as possible as open, because if the patient doesn't feel any complaints related with the fistula itself, like huge leg edema or some cardiac problems like palpitations or not, then I am trying to keep them as open as possible. And maybe for
what about
some of my patients, I am maybe keeping them for 1 year. So it is okay, because the patient has no symptoms related with fistula, and the stents are open. So why not just to close the fistula? So this is a very difficult question. I think the most important one, how long we should keep the fistula. And this is one of the most important questions that I believe.
What about Professor Munir Nazal and Professor Kapnik? What do you do in your practice? Professor Cap?
Go, Dr. Kaplan.
So I admit that I've not done an endovenectomy. The results of endovenectomy, at least for my colleagues, are not great. And there are, depending upon what you're doing endovenectomy for, depends upon your results. So obviously, if you're doing an endovenectomy that doesn't need it, you're going to have great results. In terms of keeping the fistula open, I've heard anywhere from 6 weeks to 6 months. And I don't think anybody knows the right answer.
So I can say really, we were doing fistulas in the 80s with Dr. Bo Eklof in Kuwait, thinking that the fistulas will help the venous thrombosis after thrombectomy. We used to do open thrombectomy actually at that time. And we used to keep a fistula. It's why I learned it from, it's called actually Bo fistula even. Bo Eklof, his name. So, but in the United States, in our venous practice, for chronic occlusion, 0 fistulas. If we do stenting, endophlebectomy, we did a limited number, 3 to 4 cases. But the reason we don't do more, because you have to evaluate the patient very well to decide, is it really okay to do the endophlebectomy? If the patient has no good inflow, whether femoral or deep femoral, you will not have a good result. So the problem with the endophlebectomy is to evaluate the patient. That's why actually I'm looking at starting randomization, stenting below inguinal or endophlebectomy for the same type of cases, which I think with the many people joining this group, we might be able to start one. So we don't do fistula for endophlebectomy. But if I open and do open thrombectomy in a patient who has, I don't know if they have hypercoagulable condition, I don't know what's going on with them, I do a fistula, but not for chronic occlusion. What is my proof? 0 proof. There's no proof. It works.
Excellent. Thank you very much. Okay, we can continue the third part of this fascinating lecture by Professor Swat.
Okay. In this part, I will talk about the post-stent care and anticoagulation, because this is also, again, I will show you a very highly discussable issue. So after the, let's say, procedure, early mobilization is very important. So we should make them as early as possible. We should ambulate those patients. And if not possible, especially if we are doing a hybrid procedure, sometimes it's difficult to make them, let's say, mobile afterwards immediately. We should use some pneumatic compression device and maybe some neuromuscular stimulating device, and then it's important. So we should early mobilize them. If you do a percutaneous procedure, it's not that difficult because those patients just walk through and then it's okay. So, but some hybrid patients, as I told, it's difficult. And of course, compression stockings is important. Duplex ultrasound control is important. I do just after the procedure, after the, let's say, the next day of the procedure, and I always check it, and I always call the patients in 2 weeks' time to check, because if you have an early thrombus in 2 weeks' time, you have still time to make some percutaneous interventional procedure to recanalize them again. And after them, you are checking them regularly. And the most important issue about the anticoagulation, and it's inevitable after a venous stenting, because of, let's say, just after early part of the procedure, just stent struts and some intimal damage, there is a highly thrombogenic state status afterwards. So in my practice, I never stopped the anticoagulation of the patients before the procedure. I just go the procedures as their anticoagulation level, and during the intraoperative period also, we are using, the heparin, and since we are cardiovascular surgeons, we have the ACT devices in the OR, so easily in every 45 minutes, I'm checking the ACT level and I'm trying to keep them over the 200 seconds during all the procedure. Because even during making the post-dilatation, if you dilate and keep it a bit more, you can even create some intraoperative deep vein thrombosis, and that's very important. So when you are making your balloon dilatation, you should be very quick, just dilate it and deflate it. So and that's why we need a very high anticoagulation level during the procedure. And then after the procedure, many times if you go on with the, let's say, warfarin, you should keep them between 2.5 to 3.5 levels, and the follow-up protocol is really difficult. And I just look about the guidelines, what they offer. And when you look at the, let's say, 2012 and 2016 guidelines, there is no mention about anticoagulation or antiplatelet therapy after venous stenting in those guidelines. And when you look at the EHA guidelines, there is some, let's say, recommendations about it. The use of anticoagulation with similar dosing as the iliofemoral deep vein thrombosis patients, and also after venous stent placement, the use of concomitant anticoagulation is again for high risk of rethrombosis is recommended. And also when you look at the CIRSA guidelines, they also recommend the use of let's say warfarin with the range of 2.5 to 3.4 between 3. So, but again, the time of anticoagulation is again a big problem, and also related with the only non-thrombotic May-Turner patients. They say that after the procedure, they use the warfarin, or in some another group they use the enoxaparin or warfarin. So it is very, let's say, everybody has such a different protocol. So, and after, let's say, according to this article, they say that optimal antithrombotic management in these patients with May-Turner syndrome, with stenting, they still recommend any type of anticoagulation, but it's really changing. And we have the results, again, the long-term results with the warfarin, enoxaparin, and some rivaroxaban group. So a lot of different protocol. And when we go to, especially for this Delphi consensus document, which is published by Dr. Ellen Davis's group, so they, because of these different protocols, they ask some questions to the doctors, especially for this case one. It's a simple May-Turner patient, stented. And as you see, there are a lot of different anticoagulation regimens through our international colleagues. And this is a May-Turner syndrome, but this is a post-thrombotic May-Turner patient. So again, we have a lot of different protocol. And this is a more extensive deep vein thrombosis chronic DVT patients, which is stented. So as you see, again, we have a lot of different protocols. So after, according to this, let's say, Delphi consensus documents, we have 7 statements which says that anticoagulation is preferable to antiplatelet therapy for let's say first 6 or 12 months after stenting for a non-thrombotic patients, and lifelong antiplatelet therapy is recommended if anticoagulation is stopped after a stenting for non-thrombotic May-Turner lesion. So, and the low molecular white heparin is the anticoagulant. So, anticoagulant of choice in the first weeks of after stenting, and thrombophylline is essential for the discontinuation. And again, following DVT thrombolysis and iliac stenting, anticoagulation is discontinued after 12 to 6 months. But these are all different and very difficult issues. And what I do in my practice, I usually start with warfarin mainly, and then if I cannot make the optimal level of anticoagulation, just not to risk the stent occlusion, I change my patients to DOACs, and I have good results with the DOACs, and I'm now preparing my let's say publication with my results with the apixaban versus let's say Coumadin group. So it's not inferior than the Coumadin, so it's a good. And if I do let's say extensive recanalization like KVAB iliac involvement for those patients, I am also adding an acetyl salicylic acid in combination with an anticoagulant therapy. For the non-thrombotic patients in my practice, I start with enoxaparin and warfarin and continue with warfarin. And after 6 months, I stop and I go on with the aspirin for again another 6 months, and at the 1 year I stop. So this is end of this section. We can discuss.
Okay. Let us take a few short questions.
Can I say a comment really? All those recommendations, again, there's no proof for them. The only proof, people who have thrombosis, better to continue. Everything else, it's a different practice, really, practice guidelines.
Yes.
I wonder what are the strength of those recommendations, Dr. Stewart?
That, you know, I show it from the AHA guidelines. The recommendation is level is very low because it was 2A. So we don't have any randomized studies related with this.
So when we asked that question in one of the meeting in the US here, Venous, I think Dr. Kapnick was in the meeting even. Do you continue anticoagulation or not? Most of the people gave the answer, if the patient was on anticoagulation, I will continue. If not, I'll go antiplatelet. That was some people went anticoagulation, but was the typical answer everybody almost gave.
Yeah.
Okay.
You can comment, Professor Kapnick.
I agree with the previous speaker. I think that for me, I'm 6 weeks for a thrombotic. I'm 6 weeks of low molecular weight heparin, and then I am on Coumadin. My problem with DOACs is that the half-life is so short that if a patient misses it and they're hypercoagulable, the stent's going to go down. If I have a very good patient, then I would prefer to use a DOAC. For May-Thorner type lesions, you know, as soon as it becomes endothelialized, in theory, you don't need to do anything with it. So 6 weeks, 6 months, who knows?
Excellent. Do you like to take some questions, Professor Ayman? We have around 10 questions from the
Yes, I would like to get some questions. The first question from Professor Hinder Bedi from India. Dr. Bedi?
You can say the question, Professor Ayman. It's in the question and the answer button.
Yes. The question is, in my opinion, serial balloon in pre-stenting is crucial. Repeat venograms after each dilatation. It's a low flow system, so usually close spontaneously.
Do you like to answer, Professor Swart?
I think it's mainly not a question, not a recommendation, I think. But the question was related with the, I think, predilatation, right?
Yes.
Yeah, during the, as I told the first part, predilatation is really important because otherwise it's really difficult to put your stents, or you can still, let's say, put the stent, but you cannot fully open them if you do not predilatate. And it should be, as I told before, as quick as possible. If you dilate them and wait a lot, you can have an intraoperative thrombosis. That's why the anticoagulation level during the procedure is very important.
Dr. Swat, I have one question for you now.
Excuse me, may I complete the question of Professor Bedi?
Sure.
He is asking what's the incidence of vein rupture during the procedure and what's the management?
You mean the balloon rupturing?
Vein rupture during iliac vein, which is in Neglin, it was one per thousand. So I haven't seen it in my life.
Okay. Anyway. Okay. Actually, since those are really very fibrotic vessels, it is very difficult to have, if you don't force it too much, it is really difficult to have a vein rupture, but it can happen. So if you have such type of let's say, complications, you should have some covered stent grafts in the OR. Otherwise, it is very difficult. If it's a big rupture, it's difficult. But if it is a simple extravasations, or you go just outside of the vein with your guide wire, if you wait sometimes, since those are not having too much blood, such type of fibrotic veins, it is, let's say, so the only simple solution of the problem. But if it's a big rupture, then you should have some, let's say, covered stent grafts with you to, let's say, to solve the problem. But if it's a simple, let's say, small rupture, just wait, and it's okay for many procedures.
Eagerly to know your question, Professor Kabnik.
So Dr. Swat, when you pre-dilate, and I'm talking about the differences between a nitinol stent and a alginate stent, what do you dilate your pressure to?
Actually, you know, the pressure, mainly I'm not over dilatation, and mainly I'm just staying with the, let's say, recommended, let's say, level of the balloon, especially, you know.
Are you nominal, or are you going to burst pressure?
Nominal pressure. I don't force them that much.
So in a nitinol stent, as you know, unless you pre-dilate, will never get to the same size that it's measured at. So
exactly. That's why we need it a very good pre-dilatation, Dr. Kabnik.
So I don't necessarily agree with you in terms of nominal pressures with a thrombotic lesion.
Yes, that's true. This area in the venous stenting is definitely debatable, and we all know your philosophy, Professor Kabnik, about this, and your preference for using a high-pressure balloon, and that each stent alloy needs different stent strategy. But probably in Turkey, how many venous stents do you have in Turkey, Swat?
Actually, we have all of them in the, let's say, market, but the dedicated ones is not reimbursed. That's
Okay.
why mainly I am using the wall stent.
Okay. Do you like
for
to
some
present,
special
Professor
insurance
Munir?
patients, it is reimbursed. So, but the 90% I'm using wall stent.
So for the balloon, we use high pressure, smaller balloon. So we don't go very high balloon to avoid rupture. For example, if we know the stent is 14, I go to 12 to avoid it, the high rupture. This is one. The second thing, actually, I had an IVC rupture in my hands, and it was occluded. I just put a small balloon, tamponaded for 5 minutes, and put a stents. Nothing happened at all. We did CAT scan next morning, admitted the patient, nothing happened. Actually, I have one of the cases to say, don't worry about venous rupture. Don't panic only. When you panic is the problem.
Yes, for many patients, it's okay. It's just waiting, solve the problems, because
Yes.
those are fibrotic vessels and they are not having that much blood. So it's mainly, it's solving by itself.
Okay, this is great. Thank you, Dr. Munir. It is very nice comment, and thank you, Swat. Because of time, we have two short questions. One of the candidates is asking about, can you depend on the great saphenous vein as inflow?
Actually, we did some, let's say, patients, but if you just depend on the great saphenous vein, many of those is occluding. So greater saphenous vein is not a good inflow vessel.
Okay, another small question. One of our attendees is asking, is it safe to stent the distal common femoral vein?
Yes, it is safe.
Yes, I want to emphasize that. Thank you. Thank you very much, Swat. It was really a very interesting talk, and thank you for the panel. I was enjoying the discussion, and of course, it is a very nice presentation and very nice interactive session. Thank you all, and I think we have to finish this presentation, and we'll get a nice feedback from you all. And I remind my attendees, please, you have 10 questions you have to answer. and you will get the link to get these questions to get a full CME hour for this presentation. Now I think we have finished our presentation, and we'll go for the greatest another presentation. We'll go for Sergio. Now I'm honored to present Professor Sergio Janesi. Professor Sergio Janesi is going to talk about evidence-based state of art in graduate elastic stocking. Professor Sergio, he's a professor of in Freira University and USH University in Bethesda, United States of America, and he's a founder and president of the Winter Foundation. Also, he has many articles, and he published more than 60 published, and all of them had been cited more than 700 times. Professor Janesi just published a recent article on sparing, segmental sparing of the short saphenous vein reflux. I'm sure that you'll all enjoy his topic today, and please go ahead, Sergio.
Dear Lord, thank you so much, and thank you, Ayman, for the nice introduction, and Omar for the wonderful job, and all the Egyptian friends. I don't know if you noticed that I have a little homage over here from Egypt from the last time I was there. It's a present from Wasile. So with our bodies, we are separated, of course, in these days, but with our souls, we can still remain together, and I congratulate everybody for this nice initiative of being together. So I will share my screen now, so let me know if it is working for you guys. Can you see my presentation?
Yes, sir.
Okay. Okay. So the topic that I've been asked for is compression, and in particular, like the evidence-based state of the art in this. And of course, we will move away from the topic of SWAT. Wonderful lecture indeed. But maybe we can also go back to the same topic, because indeed post-thrombotic syndrome is quite challenging in terms also of compression management. I have no conflicts of interest to declare. The idea is to look also at the practical point on what we could consider the 10 commandments in compression. So 10 things we could remember every single day we are in our offices. And of course, this is always evidence-based, so you can always find the reference of what I am talking about. So over here we are in Europe in terms of guidelines, and in the second part of the talk, we will have the chance to have a look at the other countries' also guidelines, because as you remember, and it has been a collective effort for which I really thank many friends that are actually in this also meeting now that have been part of that. Guidelines are different from area to area, and if we look at the one of the European that are like published in 2018, we see that there is quite clear indication with the first two commandments, I say, in patients with chronic venous disease, but I'd like to point your attention also to the fact that they are mentioning also healthy individuals. Because indeed, compression is focusing always more and more on also occupational, for example, swelling, or also on conditions like prolonged flights that hopefully we will start to have again. And as you can see over here, the indication is quite strong in using compression in these categories with the 1B. At the same time, I'd like to point your attention to this graph that is showing us when we get the best compliance and the best pressure range. So they were pointing out over here that if we go over 20 millimeter mercury, we get the risk of losing compliance with our patients. So they were like suggesting this range between 15 and 20. I think this is food for thought for us as experts and friends and colleagues in this meeting, because other papers like this one of Raju and other that we could quote from the literature are showing that in reality it's a little bit our fault if we lose compliance. because indeed up to 63% of cases could be considered not compliant because of wrong prescription from the physicians. We know that indeed it is like prescribing a drug, so we should be really careful in what we prescribe, so in terms of dosages, so millimeter of mercury, for example. This is like a typical Italian drug prescription chart. So it's exactly like prescribing a drug. And of course, I don't want to annoy you, like specifying all the things we should point out to our patients when we are prescribing a stocking, to be sure that it is effective and that the compliance is maintained. So let's move forward with the evidence. And over here you see Forrest Gump. You might remember the movie. You remember that he was used to say that life is like a chocolate box. You never know what you're going to get. And that's a little bit in my vision, the evolution of chronic venous disease. And indeed, we should not say that compression can stop the evolution of chronic venous disease, even if we have some preliminary evidence that could suggest it. For example, this paper from Costas was showing that in patients who were operated on both legs and then using one stocking on one leg and not in the other, well, there was like easier recurrence in the legs that were not using compression. So for sure, this will be a topic of future research. I'm happy to have with us huge giants like Professor Kabnik, with whom we could discuss about the meaning of requesting several weeks of compression in the USA from the insurances before allowing the coverage of a procedure. So as you might all know, in US, correct me if I'm wrong, Lowell, they are requesting sometimes under compression to see if you really need this procedure. And the interesting thing is that if you fly on the other side of the Atlantic and you land in UK, they're actually recommending against the use of compression stockings to treat chronic venous disease if you can do a procedure. But they are also saying that if you cannot have a procedure, well, in that case, stockings could be useful. And we could discuss about this, but the way I look at that is actually suggesting that compression stockings indeed can be effective. So moving forward with our commandments, we see that it has been reported that there could be an improvement of skin changes in patients with chronic venous disease using compression. Of course, you see always the grade of evidence is not so high. And the reason for which we have this C is that, as it has been reported in the literature, it is quite difficult, of course, to have a randomized comparative trial comparing compression versus no compression in patients with the severe stages, because empirically also we know the importance of compression, and we know the importance of compression in the advanced stages like ulceration. These are nice papers, for example, showing that in specific for lipodermatosclerosis, you see the grade is going a little bit higher because it has been demonstrated that there is an improvement in the group that is using stockings in the control and resolution eventually of lipodermatosclerosis. You are all listening me right, guys? Just a little check. Can you hear me nicely or am I alone over here? All is good?
I can hear you well, perfect.
Yes. Okay, just a little check.
Yeah,
so moving forward, we go to the highest grade of evidence, 1A. And as we know, it has been highly demonstrated that in terms of recurrence, compression is really needed. Just, I'd like to point out some interesting data, for example, from this paper that is showing with the randomization of multiple studies in reality, that even if you use gravitic compression stockings against the bandage, you can have a significant improvement in the healing rate and even a shorter time. We could discuss over here about the bias in bandaging of not knowing how much pressure is really put into that bandage, because as we know, many studies unfortunately are not reporting the interface pressure, but that's a topic for further discussion, I say. As you can see, fourth commandment, grade 1A, ulcer healing and pain. So of course, in these advanced stages, we know the value of compression. And this is, I think, a nice chart showing, and I actually use it also with my patients, to show how a compliant patient to compression has a significant decreasing the risk of having recurrences after an ulceration up to 9 times. So I think we should really stick this into our mind and into our patient's mind. Now, trying to wake everybody up a little bit, Angelina Jolie over here is reminding us of the importance of compression also in the post-procedural phase, for example, in this specific indication for aesthetic treatment. In terms of liquid sclerotherapy, as you can see, it has been recommended with a grade 2B. Again, of course, mild indication, but it is reported that 3 weeks of 23 to 30 millimeter mercury can improve the aesthetic result. It has been reported indeed in the guidelines in Europe that it is recommended to use compression after GSV treatment to reduce postoperative side effects. Now, we could get into a very big discussion on this topic, because if we really dissect the literature, there are like a different point of analysis we could have. But I said that the take-home message is that we have indeed in Europe a recommendation of 1B of using compression after surgery, after sclerotherapy, as we have seen before. But we have also contradicting literature, for example, like this one, showing that after foam sclerotherapy, 15-20 millimeter of mercury versus no compression was really not making any significant difference. And on this, I would comment that maybe the pressure level should be always checked twice, because if we consider, for example, foam sclerotherapy at the thigh with such a low pressure level, of course, we know that according to the Laplace law, we will have a very low level of pressure at the thigh. So it would be like comparing no compression with no compression. So if I compare nothing with nothing, basically, of course, I see no difference. And then I like to point out that it was reported, for example, with thromboembolic deterrents, that 1 week and 3 weeks were really not making any significant difference. But also in this case, we should point out that, of course, we have 2 effects in compression. One that is the one of edema control, for which, as we know, we don't need that much pressure. If we think about the socks that tonight are leaving a dent on our legs, like the not compressive stockings, just a simple socks, we know that that small amount of pressure is able to act on the edema. But on the other side, we have to act on the hemodynamic aspects. And for the hemodynamic aspects, of course, we need higher pressure levels. So we should brainstorm together about the use or not of post-procedural compression. And I will say that, in my opinion, despite the recommendations, we are still failing in really giving an answer to that, because if we really dissect the literature, there is an evidence that is not so strong, even if we know that empirically it's a strong evidence. On the other side, we could look at the literature in another way, saying that, of course, not all patients return to symptomatic caesura. And then, of course, if we had patients with an ulcer, there is the risk of ulceration. And I'd like to take you back to the concept that we had at the beginning, for which whoever is at risk of developing venous-like symptoms or signs receive a recommendation of 1B. So again, there are different ways of looking at that, but I think that compression on this situation can help. Now let's go back to the thrombosis topic. And so after deep venous thrombosis in Europe, it is recommended to use immediate compression with a grade 1B to reduce pain and swelling. I think that the word immediate is really important. There is a nice paper that is showing the effect of central memory of the pain, of the central nervous system, for which if we experience pain, or like a pain-like symptom, we are going to have a sort of memory of that. So for example, in the SOX trial, the delay of using a stocking could have biased the perception of pain in these patients. So it's really important, also according to the literature, to start with compression as soon as possible. Back in the days, it has been demonstrated that it can even improve the walking distance of our patients who experience DVT, and of course improve the quality of life. There is evidence that it can reduce the thrombus growth. You see again the grade 1B. And if we talk about superficial venous thrombosis, unfortunately, we should work a little bit more in science in this aspect, because we see that we are missing very well designed studies with a grade 1C, even if I think no one of us would avoid to put a compression stocking if there are no contraindications in patients with a superficial venous thrombosis. Now, the prevention of post-thrombotic syndrome would really require other 2 hours of talk, and of course, this is not the case. Let's say that, again, in Europe, we have an indication to use compression with a grade 1B. And again, of course, we could open the Pandora base of the SOX trial, and we all are familiar with that, and we are all familiar also with the criticism that has been brought after that. We know about the poor compliance evaluation, the difference in patients' characteristics, the use of different anticoagulants, the use of placebo stockings that could have actually been effective in that, as we were saying before. Remember the dent that remains tonight on our ankles if you are using, for example, SOX. And then the delay in the application of the compression, that is exactly what I was saying to you before in terms of the central memory of the pain. Post-thrombotic syndrome treatment, 9 golden rule. Also in this case, there is an indication of 1B with some previous data showing, like in this paper by Latimer, an improvement in the hemodynamics parameters in these patients under compression. And then we get to the big one, which is the last one, of course, of lymphedema. Also in this case, like in the answer, it has been demonstrated that in the maintenance of lymphedema, of course, proper compression is highly graded with 1A, with pressures that are changing based on the guidelines and on the investigations, but of course are quite high. But I like also to make a comment, to be honest, because we have a big bias, in my opinion, in these investigations on the fact that in reality, I'm not familiar with any paper that is looking just at compression. These are patients that are, of course, ethically always doing some manual drainage or some other treatment part of the CDP treatment of lymphedema, for which we should really try to design properly also in this case a study to be sure that we are giving the proper light to compression, as we all know indeed also empirically it works. And with this, I could say that I'm done, but in reality I am not, because with compression we could go on and on and on. So moving toward the first part end of this talk, I would just like to brainstorm with you about the indications we have in compression in terms of postoperative care of our patients. As we know, we have to give a score to our procedure, and we have to give a score to our patient. And we know that sometimes we can find ourselves in the difficult situations of having patients that are at risk of developing a hemorrhage at the same time of developing also a DVT. And for this reason, we should always remember that in these high-risk cases, we could rely just on proper compression, combining, of course, intermittent pneumatic compression and graduated compression in the proper way. But I like also to point out to you a nice paper that eventually, if we'll have time, we'll discuss later on, that was showing that just in 19% of patients in the trauma unit, intermittent pneumatic compression was used properly. So again, we should always be sure that we have homogeneous data when we are analyzing them, because, for example, those data could have been biased by the fact that intermittent pneumatic compression was not used properly. The take-home message for our everyday practice that I'm sure we are all familiar with is that we can rely on graduated compression, stockings, and intermittent pneumatic compression if we are at high risk of bleeding, so that anticoagulation is temporarily contraindicated. Hopefully soon we will all start flying again, and that's the most common question, the one if we should use or not graduated compression stockings. Well, we all know the biases that have been reported in the different investigations related to flight and thrombosis and venous symptoms. The indication currently in Europe is to be for long distance traveling, but I like to know what in Europe we mean by long distance traveling, because it has never been really defined. And of course, in these cases, in patients at high risk, we could even think about a combination of anticoagulants and compression with a grade 2C. Some papers that I think are worthy to be remembered are the ones that are showing, for example, that after 5 hours with mild compression, we have better comfort and swelling. Also, this one, I think, was interesting, showing that the ones who were wearing compression experienced no thrombosis, while the other ones without stockings actually experienced thrombosis. But again, this is another field that is pretty interesting in my opinion in terms of research, and indeed we recently published a paper that is quite unique. It's a very simple paper, but it was always the same subject, and it has never been done always on the same subject up to my knowledge. So the bias is that, for example, in some investigations, they were putting the stockings while they were on the ground transportation to the airport. In other investigation, they were putting the stockings where they were on the plane. So there were like different situations that could change the game. Of course, it happens to us pretty frequently to be asked about the pregnancy and compression. But also there, we should really work a little bit more. And also for this reason, we are developing with the Vivian Foundation projects with the OBGYN that also for pelvic venous disorder, of course, require bigger collaboration between the two different specialties of ours and OBGYN itself. We know that compression improves venous drainage, heaviness, and tiredness and pain in these patients. Actually, not patients, subjects that are experiencing pregnancy. But we should be honest with them and, of course, stating that we have not solid data demonstrating, again, as I said before with Forrest Gump metaphor, that we can prevent the varicose veins evolution. For sure, we can say that they improve symptoms. They're like papers that are contradicting because some are showing that they could control edema, others are showing not. We know empirically they do in reality. The big topic, of course, of patients with arterial disease, well, we know the traffic light that, according to the different indications, but over 0.8 to 0.9 of ankle brachial index, of course, with proper care, we should not worry too much about the use of proper compression. When we are ranging between 0.55 and 0.8, 0.9 yellow light, so we have to be really cautious. They're like paper just recently published that are showing that even 30, 40 millimeter mercury were not really changing the game in terms of arterial, in the reality actually improving the arterial flow. Below 0.55, of course, we can not do that. I remember a very nice sentence of the master of compression, Professor Patch, who is used to say that sometimes a contraindication is a good indication. I will repeat, sometimes a contraindication is actually a good indication. So for example, in all the cases you see here on the left, even if there is some minor arterial impairment, a good compression is actually indicated, absolutely. Of course, it will not be indicated in case we are experiencing peripheral neuropathy. We all know why it is contraindicated in these cases, trophic alteration. Severe heart failure, I was pretty impressed by this paper recently published showing that if it is an heart failure that is stable, still you could use compression. So I think also in that topic we will have to dig a little bit more in the literature. And of course, if you have severe lower limb asymmetry, we know that in reality, there are multiple options also of custom-made compression for which we could rely on compression also in these cases. Diabetes, of course, and we said before, the ABI. So looking at where compression is going in the future, and since we have looked at the present actions, so we have demonstrated so far that compression is able indeed to counteract venous hypertension, to increase the cuff pump performance, to promote venous and lymphatic return. It has an action also the microcirculatory level and improving also leg oxygenation, in particular in arterial patients. I find it pretty helpful in many cases, and also it is demonstrated in a very preliminary way, I have to say. We still have to work a lot, I think, on the inflammatory cytokines because it is really easy to get biases in that topic. All these things, I would say, been pretty much solid and demonstrated. What we should really work in the future, I think, is starting from ground zero. So, for example, when we are looking at the television, when we will be looking tonight at the television, and we will see some commercial like these ones, with certified elastic stocking wannabes. I think that we as experts and as societies, we should really advocate for our patients indeed and for certified products, because if not, we really get the risk of confounding the population. This is a real commercial, for example. They are like claiming that these stockings are aiding performance and improving blood circulation. And I would like to ask you what you think they mean, the commercial guys here, when they are writing improving blood circulation. At the same time, we should be able in the near future to answer to a very simple question. I'd like to ask you what you are saying to your patients when they are saying, doctor, should I go walking? And of course, we usually say yes, but for how long? Where is the demonstration that they have to walk for 10 minutes, 30 minutes, 1 hour? And what should we tell them? Should they use or not compression if they are healthy subjects or if they are like a chronic venous disease patient? And which compression level we should recommend them eventually if we decide to give them in case they are, for example, healthy subjects. To answer to these questions, we placed some studies that are published, some of them on JVS, some on Phlebology Journal. So all the data are there if you want to dive into the literature on healthy subjects, to really start from ground zero and understand how it goes. And this is the chance to deeply thank Dr. Erika Menegatti, that is always involved with these investigations with the sport and medicine. So you see, we put people on treadmills because the first problem is always having standardized data. So we standardized the velocity because, as you can see, these two nice friends of ours on the treadmill are going to two different velocities that are at the same time with the same metabolic impact, so that we can have homogeneous data. Basically, the same people experienced walking with and without stockings for 30 minutes at a standardized pace, standardized velocity. The stockings were like 20, 30. And what we demonstrated is that after 30 minutes in an healthy subjects of walking without stockings, you have no variations in volume, while 20, 30 millimeter mercury are able to diminish by 5% this volume. Now, the interesting thing was that in the group wearing stockings, there was a significant decrease in the perceived exertion that was measured with a standardized scale that is called the Borg's scale, that is ranging from 6 to 20, where 6 is no effort and 20 is the effort you have when you are going running with Professor Luis Leon, that is a marathon friend of ours. So as you can see, in the group that was using stocking, the score was significantly lower, so showing that even in healthy subjects, after 30 minutes, there is an impact on the perceived exertion, for which the take-home message I say is, if you want really to facilitate your subjects to go walking, and of course you can help them with the proper compression. But then this subject could ask you if they can go with a dog. So can they stop and go like when you are walking with your dog, which is exactly the situation you have when you are walking downtown and you're stopping, for example, in front of a shop and you're restarting again, because in our everyday clinical practice, our patients could ask us if they have to go walking continuously or if they can walk intermittently. Now, what do we really know about intermittent versus continuous walking? There is, in reality, up to my knowledge, no literature on this. And for this reason, we placed a second study. I just like to be sure I'm not on my own. Are there still our friends over here?
Yes.
Yes. Okay, that is great. Sorry, guys, just checking out.
Yes, it's fantastic.
So with this second investigation, we went to the golf course. The golf course because we really wanted to simulate the intermittent walking, because if you think about that, when you play golf, you walk toward the golf ball and then you stop, you have your shot, and then you walk again. And I was really passionate of golf, and I was thinking that walking on the golf course was perfectly good for our leg because we are activating the calf pump. But I questioned myself about what was going to happen for real in terms of lower limb volume and perceived exertion using different kind of compression. So what we did was a placebo investigation where people didn't know what kind of compression they were wearing on. Of course, the stockings were all the same. It has been quite a serious investigation done also with the sport institutions you see over here. And we randomized basically sham, 18, and 23. The interesting part of the 23 was that one group had also the foot cover and another group had the sleeve, because your patients could also ask you, doctor, should I use the sleeve in the same way I use graduated compression stockings, or like is it different? Now, we know that at hole 1, we are significantly different from hole 18 in terms of perceived exertion. So we did the Borg's scale also in these patients to see how they were feeling at the end of the 18 holes. Now, if you look at the data, you can see that, and I was pretty impressed by this, if you say to your subjects, the anti-subjects, to go walking for the 18 holes without stockings, or with the sham, basically, in this case, you have an increase of the lower limb volume. It's not like really draining. And the answer is that very probably you are like spending more time standing up. So it's like a pump. If you don't charge the pump, of course, you have more venous dilation or like at least venous pooling. With 18 millimeter of mercury, it was possible to have no significant variation in the lower limb volume. At 23 millimeter mercury, both with and without the foot covered, the lower limb volume was decreasing by 4%. Now, this is interesting because they were again blinded, and only the group who had 23 millimeter mercury had a significant decrease in the Borg's scale, independently by the fact that they were using or not the foot coverage of the stocking. Of course, there is the bias of having compared in this case 2 different scenarios, the continuous and the intermittent walking in these 2 investigations. But in both cases, we demonstrated that a certain amount of pressure was necessary to have an impact on the perceived exertion. And I think this is important to start thinking. Of course, these are preliminary data, but it's truly our moral duty to advocate for certified products and to advocate for our anti-subjects and patients who are asking us what kind of compression they should use, for example, in their sport or everyday practice. But maybe they are not sport guys.
Sergio.
Yes?
It is very, very, very interesting talk, and I have a lot of questions. Can we get a break to answer some questions, then continue?
So I can also drink. That's fantastic. Okay, tell me.
Okay. First question, my colleague is asking a question and he wants comment from from you, then from Mark Whitley and from Victor Canetta. He is asking about your proposal that there is no routine use of elastic stocking after the procedure.
No, maybe it was misunderstood. I didn't say that there is no routine use of stocking use after the procedure. Actually, I'm on the opposite side. Even after a glue procedure, I usually use the stockings because I consider stocking an anti-inflammatory drug more than a physical agent because of what we are seeing, for example, in preliminary data on the cytokines level. So maybe I didn't understand properly the question, but if the question is if there is no routine use of compression, to the contrary, let's say that there is absolutely a routine use of compression, I will suggest it even empirically if we don't have very strong data in this moment on the evidence-based part. Now, what we are missing, in my opinion, is a solid data collection on this, for which, if you look also at the documents that have been recently published from AVF, SBS, AVLS, it has been left basically to the health professional to decide what kind of compression we should use. But maybe it was better to answer after Mark and Victor, that are 2 big experts as well. So let's see what they say.
Okay, can we get a comment from Dr. Mark?
Mark Whitley is not with us, but we have Professor Victor Canata with us. Professor Victor.
Thanks, everybody, and thanks to this giant meeting. We have more already than 100, and the program is already collapsed, Sergio. There are people outside asking to how can they go in, and they are impossible to hook in. We will improve for the next time. Okay, thanks to everybody, meaning that we are working, or the work of Ayman and Omar is succeeding very, very nice so far. Okay, my point is like this. I think the same that you, Sergio. I think everybody else should get stockings, but the problem is I would like just to ask to Lowell and everybody that they are doing procedures at the same time. How do they deal if I do Elvis procedure with phlebectomies? My trouble is always when I have my nurses who put everything to the patient and put all the compressions. But the point is, what will be it at the end and how much compression should apply to have a better view of what's going on. I usually apply at 15 to 20, and then if the patient feels that he's feeling fine, and go higher. What are, to everybody else, the first compression that should apply after a procedure is my question.
Okay. What about Professor Kabnik? Do you like to add your comment?
Yes, in the United States, it's very variable after a thermal ablation. There's not been any real good studies to show that it's certainly effective in terms of increasing the efficacy. What's been shown is that it may reduce the pain score. If you look at a visual analog score, it may reduce it 1 point. So a lot of us are tending and shying away from compression post-thermal. If we're doing phlebectomy at the same time, then that's a different story. I think we certainly would use compression, and we would probably use compression for at least 7 days, 20 to 30. And the reason for it is whether it makes the patient feel better or not, we don't want them looking at their leg all the time. No, I'm just kidding.
There is also a very nice question to you, Sergio. The question comes from Hinder Bedi, I think from India. He said his question is how to modify compression in post-thrombotic syndrome with associated arterial disease, peripheral arterial disease. Can we modify as per APBI or totally avoid it?
No, absolutely the first one, in my opinion. So again, it has been shown also with intermittent pneumatic compression last year. And there are also new devices that are combining the possibility of having both a constant pressure and an intermittent pneumatic compression always in the same, let's say, booth. So it has to be absolutely customized, I would say, in my opinion, but also according to the preliminary evidences we have. And this also in terms of intermittent pneumatic compression, because it has been demonstrated that it is able to increase the oxygenation, very probably because it is improving the afterload, the resistance that they are encountering with the venous flow. So absolutely to be customized and used. Okay. And it's a chance to say hi to my safe friend, because I know the person who made the question.
Okay. Do you like to add your comment, Professor Kabnik and Professor Victor?
Oh, well.
Yes.
After you, go ahead, Victor. I'll follow.
So if I can, I would just point out a very nice question of Rashad Bishara, a great expert from Egypt, indeed, that is asking if we should recommend compression for post-thrombotic patients who are asymptomatic. Well, if it is like particularly in the early stages, it has been demonstrated that proper compression applied in the immediate phase is able to reduce by 20% also the residual obstruction inside the deep vessel. That is translated in a reduction of 8% of the possible evolution of PTS. So in this case, I think it is pretty interesting to say yes. Okay.
Usually, sorry to okay. You're listening? I answer the question? Okay, fine. I think the problem is like this in like we are in Egypt is a hot country to like my country, and how we will be able to get those patients to follow through the stockings, how they will be able to go with the compression for more than 1, 2, 3, or 4 months. But the trouble is usually succeed when you show the patient that they will improve, that will be do better after the compression, and we have to teach them, and we keep doing it and give guidelines and show them what is the best. Okay.
Yeah. Okay. Professor Kabnik.
I just, from a point of Sergio, I certainly agree with him. For those people that have arterial insufficiency, there is a standard in terms of compression hose. There is some talk about an absolute number, which I'm not sure I agree with, in terms of 0.6 for an ABI. But I think that we need to be cognizant of the fact that it is supportive in compression.
Okay. Excellent. We have another question from Professor Wasila Taha. She's one of the most eminent angiologists in Egypt.
She's the one who gave me this, actually.
Yes, she said, great presentation, dear Sergio. In post-thrombotic syndrome, when you start to recommend your patient to put compression stocking just immediate or whenever, or he or she start symptom? Thank you for the presentation.
I would say that I prescribe that the day before they have the thrombus, meaning that
That's right.
as I said before, there is also a central memory of pain. That is a very interesting concept, I think, for which if you experience pain, then you will be more sensitive to pain, and also this will basically bias all the investigation that we had on post-thrombotic syndrome in terms of symptoms. So the answer is absolutely immediate compression, as it has been demonstrated. Now, the real question would be when we stop it, because of course, and in the last part of the talk, if we will have time, we will go through the guidelines from all around the world with the winter document we published together with all our friends last year. But not everybody agrees in terms of guidelines, but it's no more valid, in my opinion, the 2 years concept of compression. It has been published with the IDEAL study that, of course, we could stay around 6 months and then individualize the treatment. So the interesting part would be understanding when we should stop it eventually,
Okay.
if we should.
Okay, we have more than 110 attendee, and we have around 200 over the Facebook. So you have 300 vascular surgeons already joined in since the last
do my hair look fine?
Yes, you look fantastic. And
Okay.
all best wishes to United States famous surgeon in Italy. I'm sure you will become successful out of this war. If anyone have a question, he like to say the question in his own voice, you can have the command of raising your hand, and then we'll give you access to say your question with your voice. So excellent. We have now one raise his hand, Syrian Naryan, and if we can give him the access to speak. Now you have your mic on, Syrian, please.
I hope he's not asking me what was the score of my last squash competition with him, because it would be really humiliating in front of 300 people.
No. Sergio, I'm glad you can hear me, and it's lovely to see you. I just wondered if you could comment on Professor Uhl's recent research that showed that at about 20 to 30 millimeters of mercury compression, the saphenous vein is open, but the popliteal veins are closed. So this odd paradoxical finding, how would you explain that with compression stockings as you've described them?
Wonderful question, Ram, and I would say that it is not a paradox. It's a phenomenal investigation of our friend Jean-François Uhl, and there also is following the investigations of Parsh and Mossi. But it's not paradox because if you think about a sponge, like if it is the subcutaneous tissue, if you are like pushing on a sponge, the GSV and in particular the tributaries are going to fall inside the subcutaneous tissue, while it is the fascia effect that is compressing, of course, the vessel inside the muscle compartment, for which we see in MRI investigation that we have this phenomenon. And indeed, this offers us the chance to dive into the physiopathology of compression, which is not like simply, in my opinion, compression of the big vessels. It's mainly in the microcirculatory level at the end, in my opinion. And this could find an explanation also in the data we see with intermittent pneumatic compression improving the oxygenation.
Thanks, Sergio.
Excellent. I would like to welcome Professor Atif Salam, one of the most eminent professors from United States. He's has joining us, and he will be having presentation soon. So let me take another question, and then we'll continue your fascinating lecture. We have a question from Dr. Muhammad Mansouri. He said, regarding compression pressure, you mentioned in the first slide, 15 to 20 millimeter mercury is typical, but later you all recommend compression from 23 to 30 millimeter mercury, and in lymphedema 30 to 40. Does it decrease the curve?
Of compliance, you mean? The curve of compliance? Yes.
In compliance.
Well, these are, of course, this is a salad of investigations, the one I proposed to you to fuel brainstorming as it is nicely happening. So what I was saying in the first slide is that according to that investigation, they were recommending to stay around 15, 20 when you are like in mild chronic venous disease cases, because over that, you get a loss of compliance. But immediately in the following slide, I quoted Raju that published that more than 60% of cases of lack of compliance are associated with a wrong prescription. It's like wearing a jacket that is too tight, for which you don't like to wear it. But in reality, if you prescribe a proper compression, it has been demonstrated also with an investigation of a few months ago, that it is basically the wrong prescription, not the stocking per se, lowering down the compliance. And indeed, it has been demonstrated with multiple studies that education of the patients and of the physicians leads to increasing compliance. So what I was saying with the 2030 was not like that I was recommending that kind of pressure, but I was saying that in healthy subjects in whom you want to have an improvement, for example, in terms of the performance, what we noticed with this preliminary investigation is that you need a little bit more pressure. That in my way of looking at that makes sense because it is acting more on the hemodynamic aspects of compression. That requires a little bit more, not even compression very probably in terms of pressure, but stiffness. On the other side, if you want to control edema, you can stay on lower levels. Now, the one of lymphedema, of course, it is interesting as a concept, but there we are talking about a sponge that is full of fluid, for which a higher compression is usually required, but it has also been demonstrated by Most and Parch in 2015, that, for example, if you look at the investigation with the Circade, with adjustable compression reps, you have less pressure, but still the same results or even better.
Excellent. Thanks very much. I really enjoyed it very much. So we'll continue the second part of your lecture. I really like this platform because we have really good hour for 1 hour presentation, not the Congress 8 or 10 minutes. And we have really good time for discussion. So please continue, Sergio.
Okay, we try to rush up a little bit then on this topic. This one was another publication on Journal of Vascular Surgery where we look at what happened in terms of occupational, for example, edema. So the interesting part of this investigation was having always the same subject, sitting 30 minutes, standing 30 minutes, walking in a standardized way for 30 minutes, and then doing the same with the stockings. Now, we look at the lower limb volume, and we added also the bioimpedance evaluation that is pretty interesting as a data. And we also look at the lower limb shape impact on compression. That is a thing that we usually don't consider. Somebody could have, for example, a nice Prosecco bottle shape of leg. Somebody else could have a nice tequila bottle shape, which of course could have some differences in terms of the final pressure. We are talking about healthy subjects. We are talking about young subjects also, as you can see from the age, because indeed maybe you're familiar with the movie The Ring, where it was they were used to say in 7 days something horrible will happen to you, and indeed it is a little bit of a joke to say that only a resident would have been so patient and nice to come every 7 days to stay 30 minutes sitting, standing, and walking with and without stockings. The pressure here, as you can see, is lower, is a 16-20 millimeter mercury. When they were walking, we used the Tanaka's formula, that is the formula I was mentioning before, to standardize the pace on the treadmill. And this is a suggestion for you. It's really easy, as you can see, to calculate. And it allows you to have always the same homogeneous data in terms of walking. Because if not, if I go walking, for example, with Professor Luis Leon, or if I go playing squash with Professor Sriram Narayan, I will have a totally different impact in terms of metabolism. The lower limb volume was calculated with the Kuhnke's formula, so the truncated cone formula, and this allowed us to have the circumference of the leg every 4 centimeters, so that we could reconstruct also the shape in this way of the limb. An important thing we usually don't do is to measure always the interface pressure to be sure about the pressure we have over there. And then, as you can see, what happens is that when you're looking at the volumes of people walking, standing, and sitting without graduated compression stockings, What happens is that when they're walking 30 minutes, no significant difference. It is in accordance also with the data we had before. When they are standing up for 30 minutes, healthy subjects, young subjects, have already an increase of the volume that is pretty significant. There is no significant variation when they are sitting for 30 minutes, slightly increased. When they are using stockings, to the contrary, there is always a decrease in the lower limb volume. And this is interesting, but I wouldn't say that this is the big information. Now, the big data is in the bioimpedance, so the amount of extracellular versus intracellular fluid. As you can see, the liquids were really shifting according to the bioimpedance only where they were walking with stockings. So the only moment in which you have a real significant pump effect, according to this bioimpedance data, is when they are walking with stockings. So we could discuss later on about this data a little bit more. The other interesting data is this one. If we look at the interface pressure in B, that we know is the ankle, and in B1, that we know is just below the calf, basically, we see that the pressure level are more or less the ones declared by the industry. But if we look at the single cases, we see that there is a significant variation for which in up to 30% of cases, you could have not a graduated, but rather a progressive compression. So more pressure in the calf rather than in the ankle based on the shape. And this, for example, happens in my leg, where you have, for example, a little bit more pressure in the calf rather than in the ankle. But in the end, this is not affecting the anti-edema effect. And it could actually even improve the pump effect, as for some investigation always by Ugo Parch that was showing that in this condition, you could even increase the pump. Let's say that in this preliminary data, if we take out two outliers, basically there was a negative linear correlation between the pressure values and the circumferences, which is, to make it simple, translating the fact that we all have our own kind of bottle in terms of lower limb, that stockings, when prescribed properly, exert the right pressure, but it is important that we take the measures not just of the ankle, but also of the calf. And we go back to the same concept we were saying before. It's like a jacket for which you have to have the proper measurement. If not, the results won't be like so satisfying. And then let's move forward. I think we have still 11 minutes, right? So if we look, can I go forward? Hello?
Yes, you can continue.
Okay.
Yes, you have 10 minutes left. Yes.
And this gives us the idea even more that in the near future, we will have to look at compression more on the biological part, in the biochemistry of the compression, even more than the physics. And this would be a little bit of a strong comment on how we do the investigations on the biochemical part of compression, because the models we usually use are just standing up, for example, still. And we use, for example, blood, while maybe we should use urine because the metabolites are faster moved over there rather than on the other path. For this, we are literally on our knees, as you can see, collecting blood, and not only. So I hope that soon we will be able to give you more answer on this. Now we are like under a Ministry of Health in Italy grant, so there is a data embargo, and I hope soon we will be able to give you more insights. In the future of compression, the way I look at that is, for example, with the nice experience we had, and this is again a chance to thank all the friends who have been there, the last winter meeting, a collaboration with the World Ski Cup that was there. And that was the reason why we went there, because we started studying compression in the different sports. And it is very interesting to see that we cannot really say compression works or doesn't work in sport, because sport really varies in terms of the activation. For example, what we notice is that in the activity like skiing, it works a lot, while there are other situations in which it doesn't work so much. My suggestion in the future would be also to work even more closely with the orthopedic group, for which we created now this Flebo Ortho Forum that is bringing together orthopedics, because as we know, there is not so much collaboration in this aspect. And in the last part of the talk, but we are like running short in time, so I will rush up a little bit just for a general brainstorming with you in 5 minutes so we can accommodate some other questions. I really like once again to deeply thank all the huge professionals who have been part of this document that has 46 affiliations from all around the world. It is published on Phlebology Journal, it is open access, and it is dedicated to the guidelines, because before I failed you because I gave you recommendations that are the European recommendations, but guidelines are like stars, because it's like following, like when we are navigating a light that we don't know if is still existing or if it is a dead star that simply is projecting still its light. It has been demonstrated that one recommendation out of 5 becomes outdated every 3 years. So it's our duty not only to remain updated, and probably in the future we will have to do more online rather than publishing with the editorial parts period. We'll have to combine the both, and we will have to talk more together in such a globalized world, because it is not possible to live in a world like the one I'm going to show you from a scientific standpoint. Before doing the meeting, we look at the literature in different topics, 11. 2 of them were dedicated to bandaging, as you can see, adjustable compression wraps, intermittent pneumatic compression, and graduated elastic stocking. So we are talking about compression. Always we try to involve the new generation, so they were presenting the data that were previously prepared with the masters. And we included also guidelines like the ones of Latin America that are surely worthy to be known, and that we didn't know so much before. So I'm really happy to suggest you to have a deep look at the document where you can see also the Latin American guidelines. I have to really rush up because we took quite a lot of time on the questions, and I'm happy for that. But just some comments. Let me just take you to the important ones, and you can dive into that in the document. We all agree basically that compression in ulcer recurrence is fundamental. You can see over here this graph that is showing you Europe, Latin America, for example. We all agree in this moment that adjustable compression wraps are safe and are demonstrating a significant efficacy both in lymphedema and in ulcer management. We are totally lacking, in my opinion, homogeneous protocol in intermittent pneumatic compression. Based on where you are in terms of geography and in terms of guidelines, you are going to have different recommendations. And at the same time, it is important we stress out, and in the document you have the most recent literature and also topics for future research, the importance of using compression properly when you're doing an investigation. I told you before, only 19% of people in this investigation on trauma patients with IPC, with intermittent pneumatic compression, were receiving proper protocols. So these data tell us that we will get the risk of reading not valuable papers. On the other side, if we focus on stockings, again, we are basically agreeing internationally on their impact on venous symptoms. We are not agreeing so much on the venous thrombosis part, even in the same continent sometimes, as you can see in this example over here. So this is a topic that we should really dive into. This is indeed, to go back to the questions of the valuable colleague before, about postoperative compression. Look how it goes in terms of recommendation if we move from Europe 2015, 18, and the Americans guidelines. And the same thing if we talk about how long this compression should last in the post-procedural phase. We have the guidelines that are saying 24 hours and all the way up to 3 weeks according to other guidelines. Same thing for the pressure, from 16 in some guidelines all the way to 40 millimeter mercury. I will conclude with a hope that is the one of flying soon so that we can be on together also in person. We still have to define what is a long distance flight. So when we are talking about the different guidelines, if we don't specify exactly the hours, we mean we get the risk of comparing oranges and apples. You will look in the document all the future lines of research that we need. I will conclude with our last study that I was mentioning. That is pretty peculiar because it's always the same subject that you maybe recognize in this picture that was flying quite a lot, was using 15, 20 millimeter mercury. It was standardizing always 4 hours, putting the stockings always in the same takeoff moment and after 4 hours, going away from his own country without stockings, but with normal socks, and going back with 15, 20 millimeter mercury stockings. Now, the data that this was able to control the edema is pretty obvious, according to the literature we had before. But the interesting part was dividing the leg in different segments, so to assess the different variations of volume inside the leg. And as you can see, in reality, this is the example with the socks, not with the graduated compression stockings. You have quite a tourniquet effect that is pretty evident, as we know, on your ankle, and you have variations that are not really totally graduated or progressive. Same thing when you are using graduated compression stocking. Now, we could talk a lot about this data, but the take-home message is that we really have to dive more into the science of compression, because that it is. And if we will make this effort, I'm sure we will improve significantly the care of our patients, because we know empirically that it was true what Leon Vandervelde was saying in the medieval time, that it was a divine way of treating our patients. I'd like to conclude inviting you to reach out to your patients with education. With the Vivian Foundation, we have free educational questionnaires that are like a revision of the literature in different languages, so they can enjoy those ones. And I truly hope that you will be with us in fighting fake news. This paper showed that 40% of medical websites are including fake news that are usually shared 450,000 times, for which we are waiting all of you in the Winter 2021 initiative that will be dedicated to the creation of a consensus document that is already ongoing. I thank all the societies, including the Egyptian ones, that are involved. There is a form where everybody can report in whatever language, even anonymously, eventually encountered fake news in venous and lymphatic. These are tough days for COVID outbreak. So with the Vivian Foundation, we created educational videos for the patients. They are available for free in different languages. And I thank all the colleagues who took part in that, as I thank the ones who will take part in what we call the Food for Veins, Veins for Food. Lancet recently came out showing that the real problem with COVID will be starvation, because of course people who are living on the street, living with a few sources of income. So starvation will be a big thing. So Food for Veins, meaning that we will provide for free education, but we'd like to ask the ones who will attend these courses to donate, not to the Vivian Foundation, but to whatever organization that is dedicated to food projects, part of their incomes in terms of paying practice. With this, I conclude, and I thank you all for your attention, and I hope we will see each other very soon before Dubai and also in Dubai. Thank you.
It's great. Thank you very much, Sergio. It was splendid as usual. We have a very huge number of questions, but unfortunately we don't have enough time to answer. So I thank you very much, and I thank the panel very much for contribution, and thank attendees. And I leave the mic for Dr. Omar Al-Farouk to introduce Professor Ahmed Al-Sattar for the next presentation.
Thank you all. So I will stop my share, right? Yes.
Yes.
Okay. Thank you very much. Let me introduce one of the most eminent consultant vascular surgeon in Egypt, Professor Ahmed Al-Sattar from Matariya Hospital. He is going to speak about acute lower limb ischemia and its management in Egypt. And hopefully we'll open a lot of time to discussion, because I like all the panelists to tell us the impact that they have with COVID-19 on their vascular practice, each one of them. So if you like to start screen sharing, Professor Ahmed Al-Sattar.
Just a moment, and thank you, Dr. Omar. I just present my lecture now. Just a moment.
Let me take this opportunity to tell the impact that you have COVID-19 on your practice. Professor Swat, what is the effect of COVID on your practice in Turkey?
Actually, at the moment, as maybe in all countries, we stopped all elective procedures now, and we are just doing the emergency procedures. And you know that according to the, let's say, explained emergency cases, as only the deep iliofemoral deep vein thrombosis, acute iliofemoral deep vein thrombosis is accepted for venous as an emergency procedure in the venous system. We are just able to do those procedures. And I think one of the most other important issues, the anticoagulant of the patient, because many of patients who was on warfarin cannot go on for their regular checks. So I think this is one of the important part of this outbreak.
Okay, what about Professor Mus'ab Suleiman? He is the head of the vascular department at Mansoura University. What is the impact of COVID that you have at Mansoura, Professor Mus'ab?
Dr. Omar, I am glad to be here with you. And actually, we have a lot of things that we need to discuss during this COVID disaster, as I always say, to explain it. First thing, I have canceled all the elective surgeries. Only for the critically ischemic limbs are allowed, and as well as patients with renal failure. Otherwise, for the sake of the personnel who are health givers, we canceled all elective surgery. One thing that I needed to highlight was about the was there any value of anticoagulation during the therapy protocols of COVID? And many of the issues have been raised so far, like the incidence of deep vein thrombosis for hospitalized patients. We are searching for that now. And our, as you know, we are one of the centers that carries the high impact of this pandemic, together with Acute and Ain Shams universities. So we are looking for this part. Is there any incidence of DVT rising for these patients? Any incidence of pulmonary embolism for the hospitalized and intubated patients? We are looking for these patients now. And I have a certain glimpse of observation for my patients who have been used to be treated with hydroxychloroquine as a part of therapy for vasculitis. And I have surveyed many of them. Do you have any suffer during this impact? And I didn't find any of them in the vascular surgery department as well as the rheumatology department, that these patients seem to be protected in some way. This may give us some chance to discuss these points later during this disaster.
Excellent. What about Professor Victor Kanata? How it affected your vascular practice?
What do you think? I'm gonna start doing, you see?
Yes, I see.
I'm working in delivery right now.
What about Professor?
The trouble is like this: we shut down everything. We just taking care of some kind of wound that I have, diabetic foot. We are doing just emergency procedures and taking care of the patient who just require everything. Over here in Paraguay, we start everything early. We just already in quarantine from the 10th of March already.
Okay. And what about Professor Kapnick? All our prayer is with United States and with New York. I'm sure you will pass quickly and you wouldn't surpass the 60,000 mark. I hope much less. How it affected your practice, Kapnick?
So my practice, venous practice, is non-existent now. We only do phlegmasia, and it has to be a significant phlegmasia to intervene. Even an acute iliofemoral without phlegmasia may not be going to the procedure room. We're seeing a lot of venous thrombosis and arterial. We're starting to see some arterial thrombosis. One of the patients, one of my colleagues, had a cold leg, and it was secondary actually to COVID thrombosis. The patient died on the way to the operating room. So the decrease in pulmonary functions that we're seeing, and people are reporting pulmonary emboli, I think that what we're seeing is venous thrombosis there, or pulmonary vein thrombosis. We have to be careful. And the question is, should these people be anticoagulated? And that's what's going around at this point.
Yes. Excellent. What about Professor Haytham? Professor Haytham with us? We can open the mic of Professor Haytham. Or maybe he's been called for an operation. Okay, are you ready, Professor Ahmed Abdel Sattar? Are you ready, Professor Ahmed Abdesattar? What about Professor Atif Allam from United States?
I'm ready now.
You're ready. Okay, you can start, Professor Ahmed.
Okay. Can I start now?
Yes, you can start now.
Okay. First, thank you, Dr. Omar, and this is a very big and very interesting symposium all over the world. I was thinking it is just for our attendees in Egypt, but now it is very big and expanded along the world. Thank you very much, and I would like my lecture to be light, and it may not a very challenge like that presented by Dr. Sergio and Surat, but it's very simple and will give us some important points that we are interested here in Egypt. So the presentation will be acute limb ischemia. Are you hearing me?
We are hearing you, but we cannot see the PowerPoint presentation. We see your iPad screen.
Why? It's not. Just a moment.
You need to press on PowerPoint. So, Professor Kapnik, I would like to ask you, do you think the COVID-19 is a hematological disease or it's a pulmonary disease? Because the point that you are mentioning seemed to be really very interesting. So if you like to elaborate a bit more. If we can open the mic, Professor Kapnik, I think you can. Professor Kapnik, if Mr. Khalid can open mic.
We lose everything. We lose everybody right now. We are down.
I am here.
It's now.
Professor Kapnik is here.
Yeah, I am here. I wish I was a rock star with COVID-19. However, I'm not. But I think it's a combination, and I think it's synergistic between pulmonary issues, which we know, and or pulmonary vein thrombosis or venous thrombosis there.
Actually, for the patients with COVID-19, it is recommended to continue on the anticoagulation of the patients. And we have some recent publications that the anticoagulation should be continued on the COVID-19 patients. So we have not that strong evidence, but we know that the anticoagulation is improving their lives. And until the time that the patients if they have the disseminated intercoagulability, we should use the anticoagulation, and mainly the low molecular weight heparin are now, let's say, offered for those patients.
We're using a D-dimer. If the D-dimers are really elevated, then they get anticoagulated.
Yes, D-dimers, fibrinogen levels, they are all affected from the virus.
Okay. Welcome, Professor Atif Salam. If you tell us how COVID-19 affected your practice.
Thank you for the good work that you and your colleagues are doing. And this will definitely benefit the training of the Egyptian doctors interested in vascular surgery. As far as the impact of the virus on practicing of medicine in general in the United States, and particularly in Atlanta, where I live, everything is a standstill. Only elective, only emergency surgery is done. And most of the OR rooms have been converted to ICU, including our hybrid room. I was interested in the discussion about the vascular impact of the virus. Of course, we are at the very early stages, And I am sure there will be many, many papers that will appear in the literature after some of the scientific studies going on, especially here at Emory. We will know more about the impact, of course, on the lungs, and then the side impact on the organs of the body that lead to death at the end due to multi-organ failure. So that's where we are. Now we are doing exactly what you're doing to maintain the training of our fellows at Emory and residents. 3 Zoom conferences at 6:30 in the morning, 3 days a week, and then open format for the residents to contact the faculty with questions. And then there is a reduced staff volume in-house, definitely much, much less than the usual, to attend to surgical complications in medical side, as well as emergencies.
That is excellent. And I would like to invite you and all your team to share with us your experience in such a great battle. In the webinar capability, we can accommodate up to 10,000 attendees. And I'm sure we'll benefit from your huge experience, Professor Atif.
Thank you very much. And at another time, I would like to hear from you and Dr. Ayman. How did this great work put together in Egypt? It really gives me a great pleasure. The technology it travels very fast and very far, which means that nowadays education is available more than ever for those who are looking for it.
Absolutely, absolutely. Are you ready, Dr. Professor Ahmed Abdel Sattar? It seems he still have a problem with his connection, and we did plan for that because we are vascular surgeon, and we always have a plan B installed. So I will, at the moment, share my screen with you. There is a very nice video from the Royal College of Surgeons about COVID-19.
This webinar from the Royal College of Surgeons of Edinburgh. I'll begin just for approximately 45 minutes and will be followed by a Q&A session. If you have any questions.
The basis is, you know, there was a lot of guideline and recommendation lately from the American and European, and because United States, America taking a lot of the brunt of COVID-19, this is one of the very nice video, which is dedicated to surgeon, not interventionist, not anesthetist, not pulmonary interventionist, but to surgeon as a whole. And I think it was one of the best. So I will run through the video. If anyone have a question, we can stop and discuss. But to me, it was one of the best lately that I enjoyed listening to.
Good evening and welcome to this webinar from the Royal College of Surgeons of Edinburgh. The webinar will begin in just a few moments. It will last for approximately 45 minutes and will be followed by a Q&A session. If you have any questions, please submit them to our panelists using chat in WebEx or in the YouTube live stream. Attendees who submit an evaluation form after the webinar is finished will be entitled to receive a CPD certificate. We require attendees to submit their response before the evaluation form closes on the 31st of March. It may take up to 7 days from the closing date for CPD certificates to be sent via email. You'll find a link to the evaluation form in the description of the webinar on WebEx and YouTube, and in the reminder email you should have received this evening. We'll be recording this webinar and it will be made freely available on the college website in the coming days. I'll now hand over to our chair for this evening, Mr. Alistair Gibson, who's a consultant orthopedic spinal surgeon and honorary treasurer at the Royal College of Surgeons of Edinburgh, to introduce tonight's guest speaker. Alistair.
Good evening to you all. COVID-19 is causing unprecedented disruption to world health. In all countries, medical services are fast reaching breaking points due to staff shortages. Elective surgeries are cancelled, and surgeons are reallocated to certain medical and intensive care units. Through this webinar, we hope to provide the essential knowledge that will allow surgeons to act in the very best interests of their patients. I'm pleased to welcome Gregor Neal, consultant in intensive care at the Royal Infirmary of Edinburgh, to take you through what we consider to be current optimal practice. Gregor.
I will go back. Professor Ahmed Abdel Sattar. Professor Ahmed Abdel Sattar is ready to share with us his lecture about acute ischemia. Professor Ahmed, if you can share a screen.
Yes. Just a moment. Can you hear me now?
We can hear you, but we're not sharing the screen yet.
Okay. Okay. Just a moment. Just a moment. Can you see my slides now?
See your screen, and the PowerPoint is open on acute lower limb ischemia.
Okay. Thank you.
You can go.
Would I start? Thank you, Dr. Omar, and thank you, the previous lecturers, and I enjoyed them very, very much. I hope this lecture will be the last and will be a right one. So let us speak about acute limb ischemia. It is a big problem we are facing nearly every day in our daily practice. So it is a common and difficult problem. The patient outcome may be loss of the limb or death of the patient. And the overall amputation rate is 13, and the death rate approaches up to 20%. Acute limb ischemia may be embolic, thrombotic, traumatic, and maybe aortic dissection that extends to the iliac arteries and give what's called malperfusion syndrome to one or two of the lower limbs. Basically, we can say that ischemia means obstruction of the perfusion. Lack of perfusion will lead to aerobic metabolism, then anaerobic metabolism. Progressive ischemia, this will lead to cell death, cell dysfunction and death at last. And at last will be death of the nerves tissue and followed by death of the muscles. So acute limb ischemia, we have two big types. One with no underlying vascular disease and the other with an underlying vascular disease, and a big difference in the management between both of them. If there is no underlying vascular disease, there is minimal collaterals, and this needs revascularization within 6 hours, and possibly revascularization injuries are there. And these type almost always in a very small number of patients we can see now. The purely embolic with no underlying vascular disease can be seen in young people with cardiac lesions and so and so, and the number become now small and small. While with an underlying vascular disease, we have these patients has collaterals and they need emergent revascularization. Acute limb ischemia with no vascular disease, usually embolic, and as we know, it's 70% cardiac and 25% non-cardiac, maybe proximal aneurysms with showers. Maybe traumatic or acute dissection with iliac extension of the dissection with malperfusion. Acute limb ischemia is underlying vascular disease or arterial vascular disease, what's called BAG or PAD. Again, maybe embolic. Patient has cardiac source due to recent cardiac event like MI, cardioversion, endocarditis, mechanical cardiac valves. Non-cardiac causes may be due to proximal arterial aneurysms with thrombosis and distal showering. The in situ thrombosis means our acute thrombosis on top of chronic atherosclerosis. Aortic dissection is still there with malperfusion in the 1 or 2 lower limbs. We have a Rutherford classification, Society of Vascular Surgery and the International Society for Cardiovascular Surgery, or the Joint Council. We can divide into 3 classes. Class 1, Class 2, and Class 3. Class 2 can be divided into A and B. Class 1, usually it is a viable limb. The patient present with pain and intact sensory, but intact and sensory motor and motor nerves. And the Doppler findings are very important. We can have audible arterial and venous signals in Class 1. Class 2A, here we can marginally affected limb or threatened limb. The patient has pain, has impaired sensory nerve, but has intact motor. He's still moving his toes. And the Doppler findings are usually audible arterial and venous signals are still there. In 2B, it is threatened immediately. It is more serious. Here, the patient will lose his sensation and lose his motor power. And we have inaudible arterial signals, but still we have audible venous signals. The grade 3, this is irreversible stage. The patient has paralyzed and intense limb and no audible signals by Doppler. The difference between embolism and in-situ thrombosis are very important because the management is different. So the history in acute limb ischemia without BAD, there is rapid onset, prior cardiac event, but when patient has no history of peripheral arterial disease. In acute limb ischemia with peripheral arterial disease, the patient usually has big history, may or not cardiac event, and he has the history of peripheral arterial disease. On basic examination, it is called in a patient with no underlying vascular disease. The patient usually present with cold, mottled, paralyzed limb. Mottling here is very important, and I will show a picture for this. There is normal contralateral pulse and clear demarcation between the ischemia and non-ischemia. In case of PAD, we have cold bluish paraphysic limb, abnormal contralateral limb examination, and no distinct demarcation between the ischemia and non-ischemia. In patient without underlying vascular disease, usually have no prior vascular surgery. But in patient with acute limb ischemia with underlying vascular disease, a patient may have a prior vascular surgery. The most common ischemic class we see in patient without BAD is 2B, while patient with BAD usually present with 2A. We can see here how mottling is. This patient has acute lower limb ischemia, and she has no underlying vascular disease, and we can see the mottling of this left lower limb. This patient is the same patient. She has embolic ischemia in the lower limb and has embolic ischemia in the upper limb as well. And so she has a cardiac source in this patient. And this is definitely embolic, and the management here is different than if she has underlying vascular disease. This patient can gain benefit or great benefit from just simple embolectomy with Fogarty catheter. This patient has acute thrombosis on top of chronic atherosclerosis. She has this grade 3, unfortunately, and this needs irreversible ischemia. And the class 3 means this patient has no, this limb is not salvageable. Again, this dependent edema and ischemia, ischemic blisters seen in acute limb ischemia. This patient is grade 2B. She has no movements. She lost her movements or motor and sensory supply. Sorry. How we manage these cases? Simply manage approach. A patient with true class 3 needs primary amputation. Don't lose your time with such patients, and the limb is unsurgical. Patient with questionably viable limb. First, we have to anticoagulate this patient immediately with unfractionated heparin. Then we even try either to use thrombolytic therapy versus open revascularization. When we use thrombolytic therapy or revascularization, this is very important. The decision whether to proceed with thrombolytic therapy versus open revascularization depends on the etiology of the acute limb ischemia and the severity of the ischemia. Let us now put a protocol, simple protocol for each class, and we'll manage according to the class. So class 1 with this pain and viable limb, we have to have a duplex and angiography. You have a time to do like this patient still viable limb. If it is embolic with no underlying vascular disease, proceed with embolectomy with focal catheter, and this will be a very beautiful and grateful results with this patient. If it is thrombotic with underlying vascular disease, the patient has bad, proceed with endovascular intervention or open bypass surgery. A patient with class 2A, which means marginally threatened limb, still we have some time. So wrist pain, sensation loss, but intact movements, he still has motor power. So we have a time to do duplex and angiography. If it is embolic with no peripheral arterial disease, still open embolectomy with focal catheter, and we have very grateful results. But if it is thrombotic with underlying vascular disease, either we use thrombolytic therapy or endovascular intervention or open surgery. We can see this CT angio here, RGSA in a patient with class 2A embolic. How we know that it is embolic? Early in the distal subtraction angiography, we can see the embolus here as the arrow share, and in the other one, it is late photo or late GSA. We can see no collaterals around the occlusion. This means it is definitely embolic, and this patient will gain benefit from Fogarty embolectomy. Class 2B, immediate threatened limb, the limb is paralytic, immediate revascularization is indicated, but no time for thrombolysis or even angiography. Class 2B, if embolic with no bad, open embolectomy is still there. If it is thrombotic with bad, means and cyanosed limb, may need thrombus deloading first by Fogarty with direct attempt at endovascular intervention or open bypass surgery. In this patient, we can see this is the early GSA. In this patient, they have presented with acute lower limb ischemia and with occlusion in the iliac artery. This early GSA, and the last one and the other is late GSA. We can see the good collateralization around this limb, around this embolus, around this occlusion. This is acute iliac occlusion, acute on top of chronic iliac occlusion. This means the patient will not gain benefit from simple embolectomy, but we have to deal with this patient as the chronic one. This patient we dealt with. This patient, I'm sorry, in this one we can see in the right side picture that there is a stent in this patient. This patient gave a history of stenting before 1 year ago. Now this patient, with crossover, we re-stented this patient. We do another stent in the beside or overlapping with the previous one, and this is the end of the GSA. We can see a very nice flow in the iliac artery. Regarding embolectomy, usually through proximal pulse to the site of the occlusion and occasionally through the B3 exposure, and completion angiography is very important. Completion angiography to see if there is residual or thrombi or there is a chronic underlying vascular disease. So if residual thrombi is there, may need a 10 milligram recombined TBA in 100 millimeter saline for 5 to 10 minutes with clamping of both artery and vein. This will give us very good results if the patient still has residual thrombi in the peripheral circulation. But if the completion angiography show a diseased arterial vessel, this may need endovascular intervention, as we mentioned in the previous one. Then, according to then the thrombolytic therapy may needed in class 1, class 2A by still tissue plasminogen activator through a fountain catheter and an access sheath for 12 to 24 hours. Heparin in the side arm of the sheath is very important. Thank you very much.
Excellent. That was excellent presentation, Professor Ahmed, and nice and sweet, as we say. And let me take the questions and the answers.
Yes.
Okay, and if anyone have a question, he can raise his hand by raise his hand the bottom on the chat, and we'll be delighted to let him speak. Okay, let me ask the first question to Professor Ahmed Absattar. Have you received any cases of COVID-19 with acute ischemia at Mataria Hospital or not yet?
Yeah, we received one case, but it's not acute ischemia. It is has another vascular disease, and we dealt with the patient according to the to our guideline rules available in our hospital. And but I think we are in a hurry or in a terrible behavior regarding to in front of any patient to have some cough or some. But our patients are liable to catch such viruses because they have very low immunity, especially those who has, we have a lot of patients has end-stage renal disease, and they has very low immunity, and they may be some cortisone and so. But we don't have a lot of cases so far, alhamdulillah.
Okay.
And
very good. Very good. We have a question from Dr. Yasser Yahya. Please, we'll put the mic on. Introduce yourself and then ask a question, Dr. Yasser Yahya. Your mic is on now.
Okay.
Good night. Thanks for this presentation. I'm Dr. Yasser Yahya, vascular consultant in Alexandria, HIO. I'm asking Dr. Ahmed Absattar, you use TPA during open surgery. You are not fear for bleeding after using TPA, or?
We use a very limited dose. And we usually close the artery and vein, clamp the artery and vein, so that the whole amount will be stayed in the limb, and this can be used only if the completion angio showing that there is residual residual thrombi. You know, if we when you do embolectomy through the femoral V, through the femoral artery, usually the focal decaster go the same way. If it's go in the anterior tibial, it will go in the anterior tibial, and it's very difficult to direct it in the posterior tibial. So if you have more than one artery thrombosed, it's better to use this technique. It's very simple technique and very useful technique. Just clamp the artery and the vein to keep the RTBA just in place inside for 5 to 10 minutes.
Let me take this opportunity and ask the panelists the same question.
Thank you.
Victor Kanata, do you do operative thrombolysis using RTPA?
Yeah, we usually use this at the university hospital. I don't use that in my private practice because the expense is very expensive over here, and they take all the money from the patients. Besides, in the ICU, we usually take that we move the patient to the hospital ICU that is free and without trouble, and we usually have very good results.
And how much dose do you give, Victor?
They start with low dose and then increases if the patient has good results. The trouble is usually the bleeding, and we are trying to titrate in the way that the PT and the patient result and how he's moving, because we have to have also the C arm trying to just in the ICU follow through how he's going on everything. I don't know what is Dr. Abdelazar, what is his experience in that stuff.
Yeah, Professor Atif Salam, do you like to tell us, do you use operative on-table RTPA infusion?
Occasionally, when you do a successful operative groin exposure and thrombectomy, and you're not if you have retrieved the popliteal pulse, but no signals distally, then of course the next step is to expose the popliteal artery. And then this is usually advanced ischemia. So we would use locally intra-arterial injection. However, these are advanced cases, and in most of the time, it doesn't really make a difference.
Yes.
Yeah. I enjoyed the presentation by Dr. Abdelazar. Just a few comments and a couple of questions. You mentioned, you covered the subject very nicely, but for our fellows, they need to know more about fasciotomy when you talk about acute ischemia. You may like to tell them how do you make this decision, and the problems that you see in some areas in Egypt or even in the United States, in certain states where the distance is a factor, the delay in diagnosis and delay in transfer. The delay in diagnosis, this patient will see an emergency room doctor who is not a vascular surgeon, and he may confuse, for example, even phlegmasia alba, because of the swelling, and he doesn't feel the pulses, and he may not hear the venous flow, and then he may diagnose this as arterial rather than venous. So teaching and education is very important here. The other thing is using endovascular approach is very popular here in the United States in big centers. However, it has its limitation as well. And you mentioned that the limb has to be viable because time is of the essence, and also you need to have the expertise available in the middle of the night, whether it's the surgeon or the team. So geography will dictate sometimes the choice between open and endo. The last thing I want to ask you, saddle embolus. when the patient presents with the saddle embolus, it's a very acute and we are trying to save life here. So if you use systemic therapy, it's dangerous because you will lyse the most proximal part of the clot, and there's no way for it to go except into the renal arteries and maybe the mesenteric. So, you indicated that in a way that embolic ischemia, probably the first line of treatment should be open from the groin bilaterally and remove the clot before it becomes life-threatening. There was some concern about using lytic therapy for emboli and the possibility of mobilizing a clot in the atrium to go to the brain. Those who are very enthusiastic they tell us and they write about the fact that even if this happens, systemic treatment will also lyse any fragments that will go to the brain. But this is something that at least we need to keep into consideration. And the last thing, you mentioned ischemia of the upper extremity. For our residents, I remind them of the anatomy of the blood supply of the upper extremities, the right versus the left. Passing a Fogarty on the left side proximally carries less risk of cerebral emboli.
Sure.
While on the right side, there are certain techniques that you should do to minimize the chance of pushing an embolus from the proximal subclavian into the right carotid artery. This is a very important topic, and I stress the point that choice between two options of treatment differs from one geographic area to another. And the surgeon should use his judgment whether he will send a patient with acute ischemia to Matareya from Cairo or from a distant place like Sohag or something, because he read or she read about endotherapy. I'm sorry I took too much time, but I'm enjoying the session.
No problem.
Very interesting
questions.
questions. Very interesting questions. This is very important. Number one, regarding the fasciotomy, yes, you are. It's very important that we always use fasciotomy. As you said, the problem of transfer of the patient. We always see the patient more than 6 hours, really, even inside the hospital, more than 6 hours. So we always see the patient a bit late. And fasciotomy, as a primary fasciotomy or secondary fasciotomy, this is a problem. But we have some guidelines or some stars as previous lecture that we have if it is more than 6 hours, if it is combined arterial and venous, if it is grade 2B ischemia, it's much better to do a primary fasciotomy for this patient. Or we can, some patients, if we can see them during the following 24 hours, and we can go to a secondary fasciotomy if the patient developed any signs of compartment in the artery or in the limb. Regarding the saddle embolus, you said this is very important. Again, this saddle embolus with the patient presented with acute lower limb bilateral lower limb ischemia. And here, we have to have a thrombus deloading. And such patients will may gain benefit from systemic thrombolysis, but and they may gain benefit from systemic thrombolysis if there is any thrombus in another area, cerebral or carotid, and so and so. But we have some limitations to this systemic thrombolysis if the patient is hypertensive or have previous strokes or have some cerebral diseases, previous cerebral disease. Still, the simple embolectomy through the groin, bilateral simple embolectomy by Fogarty through the groin is very beneficial. And we can go ahead with completion angiography, and we see. You said that I think it is better to do RTBA by the low dose and clamping the artery and vein, better than to expose the third popliteal part and go to cannulate the anterior and posterior tibial arteries. But we keep this give this stage if the thrombolytic localized thrombolytic therapy failed. So we don't have a chance even except to recanalize or to cannulate the anterior and posterior tibial arteries through the popliteal exposure.
Okay, thank you very much, Dr. Ahmed. Let me take the chance of Professor Lowell Kabnik because he seemed to be dressed in the operating hour era. And what is your opinion about operative RTPA? And do you prefer to use angiojet or Rotarex or Penumbra devices in these cases? Or what is your strategy in your hospital, Professor Kabnik?
Thank you for asking that provocative question. I fortunately have not performed any arterial surgery since 1999, and I'm strictly venous. So I will pass on that question. Thank you for the lecture. I'm learning right now about.
Okay, what about Professor Swat? Do you do arterial practice, Professor Swat, in Turkey?
Actually, not that much as Dr. Kabnik. I'm not doing too much arterial procedures, but in the daily practice, sometimes we go through maybe if you surgical simple embolectomy making a lot of impact on it, but sometimes, as you also explained, you can use also some type of let's say thrombectomy systems like angiojet, echoes, or the other ones. But I think mainly the simple embolectomy is cheaper, and if it is suitable, you can do it.
Okay. What about Professor Mossab Suleiman? Do you use? Yes, please.
Yes, Dr. Amar. It's I have a few comments for Dr. Ahmed. It's a very illustrative lecture. From our daily practice, we got to notice that first thing, we have to differentiate between embolic ischemia and the thrombotic, which means to us a thrombotic event on top of a chronic situation that usually gets in the popliteal or infra popliteal area. First thing, you have to count on duplex made by the vascular surgeon himself, just to define the site of the embolus and the age of the embolus in order to prevent fragmentation in all the thrombi. Embolectomy is a straightforward way for the recent embolus through a surgical approach, but for the thrombotic events, I prefer the endovascular from the start, starting with aspiration and then dilatation for residual occlusive lesions, and ended with thrombolytic therapy, which I prefer to use it in a high at the maximum dose and then taper it overnight, because starting with a low dose used to give us a very kind of dilemma, because we have open vessels in 12 hours and then they re-occlude once more by the end of the next day. So we used to use it in a high dose and end up with a low dose. The thing that Dr. Atif Salam has issued is very important, is that you got to moderate the dose of anticoagulation when you have a type 2A, because you may need urgently at the same time to do a fasciotomy. So you got to moderate the anticoagulation dose just in case you may need this fasciotomy. Otherwise, I'm glad to hear all the gathers and I'm glad to receive their comments, which are very fruitful and helpful for all of the audience.
Okay, so I would like to thank everyone, especially the famous, well-known panelists, and also all the participants. And I'm very sorry about the limitation of 100 NTD, but the next time the limit will be up. But there was around 300 observing our webinar over the Facebook page. And hopefully over the next period, we'll start to have an online courses with practical vascular dedicated workshops, totally on live platform. And I would like to thank you very much, Professor Loyal Kapnik, to take such precious time to spend with us. Professor Victor Kanata, Professor Swat, Professor Sergio, Professor Atif Alam, Professor Mut'at Suleiman, everyone. Thank you for sharing such a great time. We're all praying for United States to pass very strongly, Italy pass very strongly, Turkey pass very strongly like the COVID era and back to normal, and we will be benefit that we already have a very nice teaching platform and a way that we all can be move as one unit, and we encourage our education. Sorry, there was too many questions we're unable to answer. If you like to add any final comment, Professor Ayman, before we end the meeting.
Okay, thank you, Professor Omar. Thank you all. First, I would like to thank the attendees for joining us. And then I'd like to thank our great speakers, Dr. Ahmed Al-Sattar, Dr. Sergio, and my dear friend Swat. I am indebted really for the panel. They are very eminent Class A speakers. They got a lot to spend 3 hours with us. Thank you, Lowell. Thank you, Kanata. Thank you, Professor Salam. Thank you very much, Dr. Munir and Dr. Mahmoud Bashir. Of course, I thank Mark, and very great thanks for Professor Lowell Kapnik. Before I go, I would like to invite you all for next Friday at 6 p.m. Cairo timing. Dr. Munir will discuss with us the aortic emergencies. Then we have a very with how to deal with challenging cases with IVAR by
Samer Qusayr.
Yes, by Samer Qusayr. And lastly, and not least, Professor Victor Kanata will discuss CLACS laser and sclerotherapy in class 1 or in C1 patients. There are 3 very nice talks, great speakers, and very great and wonderful panel. Thank you all, and see you next Friday at 6 p.m. Please mark your calendar. Thank you, and have a nice evening, and please stay safe. Thank you.
Okay.
Lastly, before I go, I would like to thank Prime Company and Mr. Khalid for great effort, for support to make this event as great as we all see. Thank you and goodbye.